Hello, everyone. Welcome to day 2 of the Medication for Addiction Treatment Conference 2021. And I would like to welcome you today and welcome to September. I will be your MC for today, and I am really excited. My name is Christina Weltzine. I'm a mental health clinician at the Division of Behavioral Health. And I will just take a moment and take a deep breath and encourage everyone to do the same as we start on day 2. So if we could just have just a moment to center and allow me to catch my breath, I'd appreciate that. Thank you. Thanks, everyone. Yesterday was just a wonderful presentation day, the music, the speakers, the messaging. It was very moving, and I hope everyone enjoyed it. And we are absolutely looking forward to today as well. So again, I'd like to welcome you. Today marks the first day of National Recovery Month. This observance is held every September to educate all Americans that with adequate support, people with substance use disorders can and do live healthy and fulfilling lives. The 2021 National Recovery Month theme, Recovery is for everyone, every person, every family, every community, reminds Alaskans in recovery or seeking help that no one is alone in the journey towards recovery. Well, every Alaskan's recovery journey is different. We are all in this together, and all of our lives improve with each person that finds recovery in our communities. Thank you all for wearing purple to kick off National Recovery Month and to show your support for individuals on their various pathways of recovery. We will take a snapshot of all of those who wish to participate. So we will be doing a clip, which is just a camera piece to recognize any of you that wish to smile and be seen together with our purple backgrounds and hopefully a purple outfit or any type of purple earrings or anything designated to support recovery. So for those of you that wish to participate, if you do not care to, that's fine as well. Please turn off your camera and I'll give you just a minute to do that. We will be taking 3 rounds of photos and I will count down to each round. So please be ready to smile. So if you don't choose to participate, please turn your camera off. And so I'm going to do the first countdown, and this will be a 3, 2, 1 smile countdown. All right, so ready? 3, 2, 1, recovery. Click. So let me do the next round really quickly. So here we go again. 3, 2, 1, smile. Oh, look at those smiles. And one more. Thank you all for this. Ready? 3, 2, 1, smile. Yay. Thank you. So before we start, and please, if you would care to turn your cameras back on, we're done. Thank you for that. So we will do a brief housekeeping, just some reminders. Before we start, we'd like to go over a few housekeeping items. Okay, please introduce yourself in the chat. I see that folks did that right away from the beginning. Thank you. Please let us know your name, organization, and where you're logging in from. Our presenters have created presentations as engaging as possible, so please join us by participating in polls, questions via the chat, and various activities that presenters have planned. And we enjoy seeing folks, so when you're comfortable, please turn your camera on here or there. If you're having any difficulties with audio or viewing presentation, please chat to event support for assistance in the chat box. During the conference, all attendees will be muted. You may submit questions or comments, again, by using the chat feature. I'll be acting as a moderator and read the questions to the presenter that you have logged into chat at the end of each presentation. So again, please feel free to put questions for the presenters in the chat, and I will be monitoring that and trying to get to your question for the presenter at the end of the presentation. Just a couple more housekeeping items. All presentation resources or materials are being made available and will be on the MAT conference website under the logistics tab on the conference website. If you need any assistance to accessing this website, a member event support will be putting it in the chat bar now-ish. The MAT conference website will be available throughout the year. So please feel free to double check and check in on these resources over time. We ask that your Zoom name include your full name and matches the name you registered with for the conference. This will help us keep track of your attendance for continuing education. Speaking of which, continuing education, there's a little, prompt. It's based on your completion of the MAT conference participant evaluation and the logged duration spent within each presentation you attend. The MAT conference participation evaluation survey link is sent on the final day of the conference to the email that you use to register for the conference. The completed evaluation is due on 9/16/21 and is required if you want a 5th annual MAT conference certificate of completion. Almost done. Continuing education will only be available for those who attend the conference in real time. For more information, please visit the MAT conference website for the frequently asked questions. Please see our agenda on the screen here for the daily program overview. There will be showcasing of our Resilient Journeys video series. Hopefully you were able to tune into some of those yesterday during the breaks. Even if you just have it on in the background, I did. There's some wonderful stories, and this was very powerful. The series was created to promote recovery, hope, and resiliency for individuals who have lived experience with substance use disorders. After the video, we will welcome our first keynote speaker, Dr. Richard Rawson.
My name is Rudy, and I am an addict, alcoholic. Addiction impacted my life to the point where I was towards the end of my addiction. I was, homeless. I was sleeping in my car, not necessarily by being forced out of my home or whatever. It was just more like I was ashamed of who I was. I wasn't a good father. I wasn't a good son. I wasn't a good partner. I was completely filled with shame and guilt, which further drove me into my addiction, and I was completely selfish and self-centered. And the only thing that mattered to me was getting my next fix. And it wasn't even really about getting high anymore. It was just about getting well. I couldn't live life on life's terms without getting high. I checked myself into treatment in 2013, May 2nd. And it wasn't even really something I really wanted to do. I didn't even really know what I wanted out of this because I didn't know how to live my life any other way. Once I got past the withdrawals and I was able to participate in 12-step programs and the support system that was there for me and kind of meet people that were on the same path, it got a little bit easier. I'm not going to say that it was peaches and cream when I got home from treatment. It was still tough because I had to clean the wreckage of my past. I couldn't just go to treatment and then come back and expect everything to be well. There was a lot of work to be done because I created a lot of mess. I was still acting out, but my recovery has given me the tools to live life on life's terms without acting out of pocket, just acting like a quote unquote normal person, just be able to take it for what it is and move on and let go. all the materialistic things in the past 8 years that I have gotten, like job opportunities, just like the raises, the money, of course, like a drug addict wants to see that kind of stuff. You have to see some kind of result. And those things are nice, but like once I was able to like look past that stuff and be like, for my own self growth, like I have value, integrity, all the things that I had completely lost, to my disease, that, I have got that back in tenfold. So for me, my recovery is, helped me in so many different ways that it's really amazing, because at 5 years of recovery, my kids' mom, my at the time fiance, went back out using. I was able to take that for what it was, take my kids, and now I have full custody of my kids. I'm able to be a father, be there, and I'm dependable. I could not do that without my recovery. I'm not able to do that kind of stuff. Every morning I drive to the same place and I reflect on my life, on where it's at today. And it's like a morning meditation thing. I reflect on where I'm at and where I've been. I will never forget where I have been, because that place of hopelessness was beyond painful. But like for me, having the support and like, participating in 12-step programs and like working with others, I'll be the first to overlook my own success. But when I get to see that in another addict, get their life together, get their kids back, or, and the light open up in their eyes, just getting it back together. For me, that's a huge payoff, not necessarily that I had anything to do with it, but I know what it's like to come from the gutter. So for me, like working with others and staying in the recovery community, because people, places, and personalities, will always get you caught up. So I tend to like stay where I'm comfortable with my recovery. The only really stigmas I personally face, and it took me a lot of time to like realize this, is like the only stigmas I was able to put on myself were because I put them there. I have huge empathy for the man or woman who's out there still struggling with addiction. Stigma wise, I feel like people could be more open-minded. They don't realize if you were to walk a mile in their shoes, could you do it? But these people are struggling on a day-to-day basis, and people are dying, and that's the harsh reality of addiction. For me, like, I think if we open our eyes to this and stomp this stigma, that and open our eyes to like the solution rather than the distraction, I think it would be a lot better.
Thank you. I just want to acknowledge Rudy and appreciate his courage to share his journey and his message. That was very powerful. So I am pleased, excited to welcome our first speaker today. I would like to welcome Dr. Richard Rawson. Dr. Richard Rawson is a professor emeritus at the UCLA Department of Psychiatry and a research professor at the Vermont Center for Behavior and Health at the University of Vermont. He received a PhD in experimental psychology from the University of Vermont in 1974. Dr. Rawson conducted numerous clinical trials on pharmaceutical and psychosocial behavioral addiction treatments for the treatment of individuals with cocaine and methamphetamine disorders. He has led addiction research and training projects for the United Nations, the World Health Organization, and the U.S. State Department, exporting science-based knowledge to many parts of the world. We are very grateful to have Dr. Rawson this morning present for us on methamphetamines. Please remember, if you would like to ask a question in the chat, we will go to approximately 9:45, and we will then hopefully get some questions and answers in at that point. Dr. Rawson, good morning.
Good morning, and Thanks for the invitation. My name is Rick Russin. I worked at UCLA for about 40 years. I started working in the area of addiction in 1974. The early years were with people with heroin addiction, Vietnam War era folks. And starting in about 1980, the work I did has been almost exclusively on stimulants. I did a lot of work at UCLA on a whole variety of topics, behavioral treatments, brain imaging studies, effects of methamphetamine and cocaine on cognition, and a whole range of other things. In 2015, I moved back to my home in Vermont, where I set up an animal rescue. And by the way, I just rescued 2 puppies, and they're in the back room right now, but you may hear them. They're still getting used to being here, and I apologize for that. But I got here in Vermont and intended to do animal rescue stuff, but the stimulant problem has followed me here. And starting in about 2017, I started getting requests to do talks on cocaine and methamphetamine, mostly methamphetamine, as it has become a major problem. And in 2018 or so, we started seeing increased use of methamphetamine in many parts of the country. And about a year later, we started seeing a dramatic increase in the number of deaths associated with cocaine and methamphetamine. So I've tried to update all my materials. The 2021 situation with stimulants is very different than when I was doing the work in the 1990s and 2000s. The drugs are very different. They're much more lethal. And hopefully I can give you some of the highlights or lowlights of what the current situation is. I've got too much information in this talk, so I'll be skipping over some slides, but I wanted to put them in so that you'll have them at the end of the talk, since you'll be able to download the talk, or they'll send you a PDF of the talk, and you'll have the information even if I don't cover it in detail. Right now, I'm also have a position at the University of Vermont, the Center for Rural Addiction, and most of what I'm doing in this regard is dissemination of information about cocaine and methamphetamine and the current status of evidence-based treatments. So this is what I'm talking about, the overdose epidemic of the past 20 years, a little over 20 years now, starting with the gold line going up in around 2003. That was prescription opioid deaths, deaths related to prescription medications. Those started to level off in around 2010. And at the same time, the green line increased. That's overdose deaths from heroin. So our prescription opioid crisis was pretty much supplanted by a heroin overdose death crisis. A few years later, 3 or 4 years later, you see the red line shooting up. That's the fentanyl overdose death situation. And the blue line are deaths associated with cocaine and methamphetamine, some involving fentanyl, some not involving fentanyl. The number on the top, on the middle of the screen, there's 70,000 deaths in 2019. That number is 93,000 deaths for 2020. So we saw a huge increase in overdose deaths during 2020, undoubtedly contributed to by the pandemic, but also contributed to by the fact that these drugs are much more deadly than we've ever seen before. When I would do talks in 1990s and early 2000s about methamphetamine, I never talked about overdose death. Overdose deaths were relatively rare, but now we're seeing very high rates of death. So one of the take-home messages today is that if you've been treating people, say over the last decade or 15 years with methamphetamine problems in Alaska, be sure you're aware that the drugs you're seeing now are different. The methamphetamine is much more lethal, and growing amounts of methamphetamine and cocaine have fentanyl in them. So we've compounded the problem by seeing these drugs mixed together. This gives you a little bit of different picture on this. Cocaine deaths more than tripled from 2012 to 2018. Psychostimulants, including methamphetamine, increased by 5-fold over that 6-year period of time. And as you can see, it's relatively similar. So although we think and talk a lot about the methamphetamine crisis in 2021, cocaine is still there. People are still dying from cocaine. A headline I had in the local newspaper from upstate New York, right next door, was they had 8 overdose deaths in the small city of Plattsburgh, New York, from cocaine laced with fentanyl. Much of the stimulant drugs that we're seeing, especially cocaine, now have fentanyl involved with them. There's a difference in who these different drugs are affecting. The cocaine death situation is predominantly among non-Hispanic Blacks. As you can see, that's the green line, and the increase starting in 2015, and that's per capita deaths on the left, on the y-axis, among non-Hispanic Blacks is much higher than among other groups. So within, and that also reflects the geography. In the large East Coast urban centers where you have a predominance of African Americans, that's where we're still seeing lots of cocaine deaths. With methamphetamine, it's very different. With methamphetamine, the blue line here, by far double any other group, is American Indian, Alaskan Natives. There you're seeing a much higher death rate than among other groups. And so when I'm talking today about treatment, certainly getting evidence-based treatment for those folks is essential, because it's no longer that people who come into treatment, well, if they stay in treatment, that's great, but if they drop out, they'll come back eventually. Or if we have to kick them out because they don't follow the rules, they'll come back eventually. Not true now. You kick them out of treatment and they're likely to be dead. So the rules of the road and our priorities in providing treatment for people with stimulant use disorders has shifted. It used to be almost exclusively on getting people into recovery. We didn't really worry about overdose death with stimulants. Of course, we have with opioids. The last 15 years of the opioid crisis have taught us that our first priority is to keep people alive. Dead people don't recover. So now that same message is true for people with stimulant use disorder. It's no longer, well, if they fall out of treatment, they'll come back later on. They often don't come back because they've often overdosed. So that's an important distinction in the current methamphetamine situation compared to what we saw back in the Breaking Bad days and the days of people making their own meth. The methamphetamine we're seeing now comes across the border for the most part. It's manufactured by the cartels, and the deaths associated with it are a result both of more of the drug coming in and the drug being more lethal. This gives you some idea. In 2000 through 2004, the average purity was somewhere between 35 and 50%. Now it's almost 100%. So the drug that's coming in is much more potent, much more pure, and much more potent. Potency really refers to the type of amphetamine that's being manufactured, and the kind that we're seeing now has almost 100% potency and 100% purity. So it's a really different drug. Cocaine-related deaths have gone up, and this reflects that the cocaine-related deaths are in greater a degree a result of the fentanyl in cocaine. The purple bars along here are the number of people whose drug deaths were directly related to cocaine. The increasing blue boxes on the top of those are those who had both cocaine and fentanyl. So these are people, many of them, who went out to buy cocaine, thinking they were buying cocaine, and end up with fentanyl and overdose from the opioid. That also is happening to a greater degree with methamphetamine. Now, the heroin supply in the United States is almost completely taken over by fentanyl. And so this deadly drug, which 20 years ago would have been mind-boggling to think that fentanyl is on the street, it's now everywhere. I've got a friend who opened a clinic in Northern California last week. His first 10 admissions have all been fentanyl, individuals using fentanyl. So it's an incredibly dangerous drug. I'm sure you're familiar, fentanyl, it only takes a very small amount, and it's not clear. It's real different all around the country. I don't know the situation in Alaska. In some parts of the country, the supply they get here in New England, the cocaine supply all has fentanyl in it. It comes in that way from Mexico. The methamphetamine supply, not so much, but it's increasing. So for people working in emergency rooms and ambulances, when they go out for an overdose, it's a much more complicated situation. They may be dealing with a stimulant overdose, which is one set of symptoms and problems. They may be dealing with an opioid overdose, different set of symptoms and problems, different treatments for both of those, or they may be dealing with both at the same time. So this is part of why we're seeing so many more deaths than we've ever seen before. The COVID epidemic, I mentioned, this is a little bit dated slide. It only went through August of last year. The final number in 2020 was 93,000, or about a 26% increase in deaths over 2019. We've never seen a rate of death increase that much. This is really, if it wasn't for the COVID public health crisis, the overdose death crisis would be headline news every day because it's so severe, but it's been buried in many ways in the COVID pandemic situation. And the COVID pandemic, no question, has contributed. I won't go into detail on that, but certainly I suspect you've already had some information on why the COVID epidemic has resulted in a higher overdose death rate. This just shows a little bit of a blip of this only goes through March of last year. So you can see the escalation. That line just kept trending upward for the rest of the year. I'll skip that. As I mentioned, a lot of the drugs now are being mixed together. This is data from St. Louis, 2018. This just sort of caught the beginning of this. This is people coming into treatment for opioid use disorder. That is, they're presenting for treatment with buprenorphine. They want to get into treatment with buprenorphine. And in 2011, about 20% of them, 1 in 5, was also using methamphetamine. By 2017, that number went up to 1 in 3. Recent data from St. Louis say this is about 1 in 2. So about half of the people presenting for treatment with opioid use disorder also have methamphetamine on board. So when you're now treating someone for their opioid problem, a good portion of them are going to be coming in with not only an opioid use disorder, but also a stimulant use disorder, and many of them an alcohol use disorder. So it's that adds challenges to our treatment with those populations. This just gives you a quick snapshot of data. This is from a small project here in Vermont about 1.5 years ago. Of the people who were in medication-assisted treatment, 66% had used cocaine in the last 30 days. 75% had used any stimulant, including methamphetamine. So of our patients who were in treatment on that, we're seeing a high rate of stimulant use. And that causes a whole set of problems that is not true for people who are, predominantly using opioids. Here's some data I just want to do a quick overview of current data on the effects of stimulants. This is an article published last year by my colleague Martin Paulus at UC San Diego. It's a great review in JAMA. He reviews the effects of methamphetamine on the brain primarily. And in brief, what he says is that methamphetamine use produces chronic damage. Chronic use of methamphetamine produces damage to the brain that's very consistent with degenerative central nervous system diseases, things like Alzheimer's and dementia, that you're seeing people cause damage to their brain that's very profound and hopefully is reversible, although there's some debate about whether you get full-scale reversal of some of the damage done. So it's not as though when people take methamphetamine, they produce an effect on the brain for the duration of the drug use, and then everything goes back to normal. It doesn't go back to normal. Things are damaged, and over time with chronic use, you get effects on the brain that are very much the result of brain damage. It's not like you're treating somebody with a traumatic brain injury. You are treating somebody with a traumatic brain injury. Methamphetamine damages the brain. It affects multiple neurotransmitter systems. One of the best ways we can see not best, but most accurate ways we can see the impact is with cognitive testing. There have been a number of studies on this. In summary, they show that shortly after you discontinue methamphetamine, there's dramatically poorer performance on a variety of motor and verbal tests. And even after prolonged abstinence, here we're talking about 4 to 6 months, you see some measures of cognition and functioning that are not back to normal, that are still slower than normal. The clinical significance of this is if you're doing behavioral treatment where you're communicating in words to the patient about their behavior and the therapy and recommendations for how they can get sober or meeting information in 12-step meetings, a lot of it is not A, being processed, and B, being retained. So in much of the work with working with this population, it's important to repeat information, not flood them with a dense information and expect they're going to remember it, because they're not going to remember a lot of what you cover with them. It's estimated that about 2/3 of them show significant cognitive impairment in the first month. And the impairment is associated with, you get worse impairment with older people who have used for more years, people who inject, and people who use more frequently. That all is kind of common sense, except maybe the injection one. But the more your patient population looks like this, older, they use for many years, they inject, they use every day or multiple times a day, those folks are going to have real trouble with their treatment. They're often going to need to start treatment at a higher level of care in some kind of inpatient or residential setting, because their brain will be too damaged and too impaired to practically start right into outpatient treatment. And you have to remember, a lot of the things they're going to be challenged with are in part due to the fact that their brain isn't working very well. So they may not show up in time for appointments. They may not follow all the recommendations of treatment. But it's important to recognize that this is a group that's really done some damage to their thinking ability. There's also effects on other systems. We see, other effects on the brain, for example, we see strokes. Stroke deaths are now a significant factor with methamphetamine. The studies have been mostly with young men, but certainly young women also. We're seeing more strokes, people in their 30s and 40s. We see brain hemorrhages. That is when people take methamphetamine, causes their blood pressure to go up, causes blood vessels in their brain to burst. You also get the other kind of stroke, which is where the blood vessel gets blocked, ischemic strokes, and you see both types, and both types can lead to fatalities. So one of the things that EMTs have to look for with a methamphetamine reaction they get called out to treat is that whether or not the person has had a stroke, because that's quite common with the current methamphetamine being used. In addition, cardiovascular disease, heart attacks, pulmonary hypertension, cardiac arrhythmias, effect on the heart muscle itself, all of those things are occurring with people at a younger age. So you're seeing a drug that, although we used to see these things with our earlier years of methamphetamine, it's much more substantial now. And many of these folks, it leads to death. This another, I won't go over this. This just talks something about the types of strokes that people have and that can lead to fatalities. Stimulant use during pregnancy is a significant health problem. This is a meta-analysis of 31 studies on women who used cocaine during pregnancy. The babies there was preterm delivery, lower birth weight, and small for gestational age. With those who used methamphetamine during pregnancy, the babies had earlier gestational age at delivery, lower birth weight, and smaller head circumference. And you were more likely to see a withdrawal syndrome from those using methamphetamine than those using cocaine. Jitteriness, drowsiness, and significant respiratory distress for babies born from mothers who are using cocaine. If the mothers continue to use post-delivery, methamphetamine and cocaine are both excreted in the breast milk, and so breastfeeding is contraindicated because the metabolite will be passed through to the baby. We know that the impact of methamphetamine use during pregnancy affects the child developmentally. This was a study we did, in a multi-site study. We looked at 204 methamphetamine exposed kids and measured them at multiple time points. At 3 years, those whose mothers used methamphetamine more than 3 days a week during their pregnancy, though at 3 years old, those kids had higher rates of anxiety and depression and attention problems. At 7 years, they had more cognitive problems. We did a separate study at UCLA looking at 4 to 5 year olds and found that 4 to 5 year olds of mothers who had used methamphetamine during pregnancy had much poorer fluency with language acquisition, the number of words they used, the fluency with which they used those words. So methamphetamine during pregnancy has profound effects. There's dental effects. If you've been working with this population, I'm sure you're aware of that. Methamphetamine does a number of things, causes bruxism, which is grinding of the teeth. The drug itself has an acidic content and can change the pH in your mouth so that you get more acidic effect. And you get more, if you're smoking it, you get direct corrosive effects of the methamphetamine smoke. We did a study looking at this, and basically we found much higher rates of dental disease with people who had been using methamphetamine than controls. Fewer teeth, lots more problems. And the more, if they used by intravenous use, the problems were more significant than other routes. That you're going to hear throughout all of this. If you've got a high rate of methamphetamine injection, then everything I'm going to talk about is going to be worse than if people are using either snorting it or even smoking it. And in fact, in some parts of the country, Vancouver, for example, one of their strategies is to say to people, look, if you're going to use, here's a pipe, you can smoke it, but just don't inject it. And that's one of the harm reduction strategies. It's being used in some places here in the US because injecting this drug really produces profound and in many cases, irreversible damage to the brain. You see a lot of this cognitive stuff with the heavy long time injectors doesn't get better. And it's so we try to discourage injection any way possible. Dermatologic effects, if you work with this population, I'm sure you've seen scratches, scars. They end up feeling like they've got bugs under their skin and they try to dig them out. And so you get a lot of bad dermatologic effects. If they're smoking it, you get burns on the lips. We did some studies in the early 2000s looking at different different groups of individuals who use different drugs. And we wanted to look at the relationship between their drug use and their sexual behavior according to which drug they used. I won't go into the data in depth, but this is the article if you're interested. What we found in virtually connection between their drug use and sex than any other drug, than alcohol, cocaine, or heroin. It's a significant problem with methamphetamine. And so as you're dealing with this population, you're very likely to have to deal with the fact that their sexual behavior became very much entangled with their drug use. And that becomes one of the clinical issues. It also has implications vis-a-vis their risk of HIV, and sexually transmitted diseases. When people with methamphetamine use disorders show up in emergency rooms, the primary reason is because they have behavioral disturbance. They're either psychotic or they're highly agitated and they're not making sense and they're bouncing off the walls in the emergency department. You also see about half of them have tachycardia, an irregular heartbeat, hypertension, 42%, their blood pressure is elevated, and hyperthermia, which is a high temperature. And here we're talking about temperatures 107, 108, even 109 degrees that can be fatal. So when often one of the primary priorities when you see someone with a methamphetamine overdose is to check their temperature and to get their body temperature down as quickly as possible, because the cause of death with people with methamphetamine use disorder, methamphetamine overdose, is often hyperthermia. This is a study that just showed they had a patient with 108 degree temperature, and they cooled him down using a body bag full with ice and probably saved his life. And that technique, although it's not routinely used, is more commonly used. This I'm not going to cover in detail. Certainly, we see a high rate of acute psychosis with methamphetamine. It's not rare. It's actually quite common. In fact, something like 70% of individuals who use methamphetamine talk about at some point in their use, they become psychotic. Auditory hallucinations, visual hallucinations, they're out of touch with reality, and paranoia and persecutory delusions are very common. The primary overarching, overwhelming piece of response that's essential is de-escalation strategies. And if you haven't had any training on de-escalation, I would highly recommend that be a priority, because a lot of the events we've seen in the last 3 to 5 years with people getting shot by police have been, some of those have been individuals under the influence of methamphetamine. And if you approach them in an aggressive manner, shouting orders at them, they often don't respond to that because they're psychotic. And so de-escalation is an essential part of dealing with their acute psychosis, as it is with their intoxication. Talking them down is the primary tool. With psychosis, we can use some of the antipsychotics that can be somewhat useful. With intoxication, some of the benzodiazepines may be useful short term, but it's mostly it's about getting them into a quiet place and sort of using de-escalation strategies to just talk them down. This talks about withdrawal. We don't have a medication like buprenorphine or methadone to withdraw people from methamphetamine. But there is withdrawal. There's always been a debate about, is there really withdrawal from stimulants? This is a study that was just published earlier this year. And the answer is yes, there is a withdrawal. It can last out to 4 weeks. There's significant impairment of daily functioning. And we really need to work on those people who come in. You see much higher rates of withdrawal with people who inject. And the treatments are not very well developed. But I wanted to put this up just to give you some frame of reference. We talk about people using frequently. This was this sample. This was, I think, 140 individuals, I think. Median frequency of use in the last 30 days, 173 times. So they were using about 6 times a day. And most of those were injections. So when you're thinking about the condition of these folks, when you see them on entry into treatment, they have very severe impairment because of this. And about well over half of them, or at least the individuals who inject, will have significant withdrawal that needs to be treated. If they also come in with tranquilizers on board, that will make the withdrawal treatment even more complicated because they'll have trouble sleeping when they don't get the benzodiazepines. And so it's as I said, this was an article from 2021, just published a few months ago. And it basically is about, yes, we have a thing called methamphetamine withdrawal. We have not developed specific treatments for it yet. So our best guess is de-escalation, use of letting them sleep, giving them a good diet, and possibly they may need some medication for getting them to sleep. But we don't have a clear protocol like we do with alcohol withdrawal or opioid withdrawal. Okay, if you've spent the last 10 or 15 years working with people with opioid use disorder, and you're now black belts at treating that population, this is different. Treating this population, there are a different set of priorities. I've already mentioned the overdose death situation, which is obviously first and major priority to prevent their overdose death. However, next comes the fact that when individuals have stimulant use disorder, they're out there using cocaine and methamphetamine, they don't think of themselves as being addicted. They think, oh, that guy who uses heroin, and when he can't get heroin, he gets sick and he has to use, he can't not use. Well, that's not like me. I can stop. And people with stimulant use disorder many of them are able to stop and start. They'll stop for a few days, a week, and then they restart. But that pattern tells them I'm not really addicted. I'm only using because I want to use, and I don't have to use. So there's this misperception that they don't have addiction. If they don't have addiction, they're not very excited about the idea of reducing or stopping their use. And I'll give you some data on this. They have an ambivalence about whether they need to reduce or stop their use. So on the front end of treatment, we have people, let me back up. When you're working with people with opioid use disorder, they have their own form of ambivalence, of course, and difficulties getting them into treatment. But for many of them, when they start getting sick, and when you have a treatment like buprenorphine or methadone, and it'll make them feel better, the idea of treatment has some direct appeal to them, that they don't want to be sick anymore. So yes, I'll enter treatment. For people with stimulant use disorder, first, they don't think they're addicted. They don't really think they need to slow down or stop. And the treatments that we offer don't particularly make them feel better. We talk to them. And if you go out and you survey people who are actively using stimulants, as I've done, about what is it they want from treatment, counseling is not high on their list. They're not really all that thrilled about the idea of being counseled out of their addiction. So one of our big challenges is, what do we need to do to get them into treatment? How do our treatments need to respond better to the nature of stimulant use disorder that makes it more attractive and appealing? And I'll talk about that when we get to treatment. They're impulsive, they have poor judgment, so they're making lots of bad decisions. Cognitive impairment and memory problems I mentioned. Anhedonia. In their early recovery, nothing feels good. Anhedonia means the inability to experience pleasure. It's essentially a dopamine depletion. You've downregulated the dopamine system. Nothing feels good. They don't have enough juice now. So when something good happens to them, it just doesn't feel that good. Nothing, they don't have their own natural chemistry to feel good. And they say things like, if this is how it feels to be sober, I don't want to live like this. I can't live like this for the rest of my life. So they don't particularly want treatment. If they start into treatment, their life kind of sucks. And so they often have significant challenges with entering and being retained in treatment. Okay, other clinical challenges. Paranoia, the drug makes you paranoid, and so you are not particularly receptive to want to talk to people about your situation because you're paranoid. I mentioned hypersexuality. That's hypersexuality while you're using, hyposexuality or sexual problems in functioning when you're in recovery. But sexuality is an issue and is part of the clinical presentation that often needs to be discussed in treatment, which is often challenging because lots of our counselors and therapists have not had a lot of experience talking to people about their sexual behavior, and that can be a challenging topic. Violence and psychosis, there's data saying that individuals who use methamphetamine when they're under the influence of methamphetamine are more likely to be violent. Again, this de-escalation stuff is real important, and clinical staffs working with people who use methamphetamine should definitely have training in de-escalation strategies so that you can manage situations with this population. Individuals with opioid use disorder, you're very familiar. Their pattern of use often is they keep using to avoid withdrawal. The not being sick becomes their priority. As the young man said in the little video clip, it's not about getting high, it's just about not getting sick anymore. Well, with people with stimulant use disorder, it's different. Their use gets triggered by this Pavlovian conditioning that cues people, places, things, times of day, emotional states, all sorts of things can trigger their craving. They don't understand it. They don't know why it happens. To them, it comes out of the blue. A classic example is money, cash. Cash is a trigger for virtually all people with stimulant use disorder. And so if they're going to get a paycheck on Thursday night is going to be a high risk time because that's likely going to trigger this bell going off in their head. They have higher rates of psychiatric comorbidity, and they're very difficult to retain in treatment. And I'll show you data on that. Here's data from state of Washington. This is 500 plus people in a syringe exchange program, 2/3 of them who used opioids, 1/3 who used methamphetamine. When you talk to the people who use opioids, 82% said that at some point in the future, they knew they were going to need to reduce or stop their opioid use or get into treatment. Less than half of those who used methamphetamine said that. So this idea that it's difficult to engage them in treatment is reflected by these data. And this is a really big challenge. Secondly, the difficulty in retaining them. This was a study published last year looking at different groups, people with different substance use disorders, and how many drop out in the first 90 days of treatment. Those with heroin, we see a 25% dropout in the first 90 days. That would be much higher if we didn't have buprenorphine and methadone. That would be closer to 70% without those medications. Tobacco, we see a 25% dropout. Alcohol, about the same. Cocaine, it's virtually double that, almost 50%. And methamphetamine, it's over 50%. So you've got this disorder that the population you're dealing with of people who don't think they have a problem, don't really want the treatment you're offering them. When you get them into treatment, they don't feel good and they don't want to stay in treatment. That's your challenge, because getting them into treatment and retaining them in treatment is the ballgame. If you can keep them in treatment, they die at a rate 1/3 of people out of treatment, which also reflects this idea of retention, keep people in treatment, don't kick people out of treatment ever for any reason. I mean, short of them pulling out a handgun. Our field remember, I've been doing this since 1974. I am extraordinarily affected by how often we've thought the answer to this problem patient is to kick them out of treatment. We don't do that with patients with other medical illnesses. We don't kick diabetics out of treatment if they don't, if they eat a pie. It's not like we feel like kicking people out of treatment is appropriate for other medical and psychiatric conditions, short of people being violent and threatening the staff. People who come in and they went out on a pass and they came back and they had a positive test. Oh, we'll kick them out of treatment, of course. So my point is, if you kick them out of treatment, they're not likely to get better. They're likely to get dead. So it's one of the practices that we've seen in our field that really, given the lethality of the drugs that we're seeing now, you can't do that anymore. It's just not ethical to kick people out of treatment or kick them off buprenorphine. This is a study done in Washington with people on buprenorphine. This population, 800 people on buprenorphine, and about 1/3 of them also used methamphetamine when they came into treatment. This is the retention curve. About 50% were retained for 600 days or so. The top line, and those are people with just opioid use disorder. The bottom line is people with opioid use and methamphetamine on board. So you see the retention is less than half. And you get this huge dropout in the first 100 days. In many cases, this is a study done some time ago, or at least this induction period was done back in 2014, 2015 for many of these patients. And you see this because this is people being kicked out of treatment. Prescribers saying, oh, you're using methamphetamine. You can't be on buprenorphine if you're using methamphetamine. So we'll give you 2 warnings, and then we're going to kick you out. When you do that, they don't get better. I mean, it's important to realize kicking them out of treatment doesn't make them better. It makes them dead. And so it's, yes, they're challenging to work with. Yes, it's hard to see patients in your clinic who are actively using another drug, but the solution to it of kicking them out of treatment is really, at this point, a bad idea. Some special groups, I mentioned people who inject have much more challenges, and also people who use daily and at very high doses. And there's some other groups that have specific issues that need to be addressed in treatment. Obviously, if you've got a big population of people, many of whom don't want treatment or who aren't interested in engaging in treatment, but they're using the drug and it's creating medical, psychiatric, other functional damage to them and is putting them at very high risk for overdose death, we have to do some things that are short of treatment. What can we do to, in the harm reduction array? I heard a presentation out of UCSF, and they're talking about teaching people that if they're going to use, and they should use with somebody, not by themselves. That's, rule number 1. Secondly, if the two of them are together and they're going to use one at a time, not at the same time. So if one of them has got a big wallop of fentanyl in their drugs and they go out, the other person, hopefully who has Narcan with them or can call the ambulance, will be there to attend to them. So there's some of these harm reduction-ish things. Certainly syringe exchanges are important. Having them carry naloxone, as we're seeing more and more fentanyl in the stimulant supply. Naloxone doesn't reverse a meth overdose, but it will reverse fentanyl to some degree. And there are other things. We really need to develop a much better array of harm reduction strategies, because a lot of these folks are not going to go into the treatment we currently have available. What are those treatments? I will skip this. This is the quick summary of this. This is the interviews I did with patients here in Vermont. They were all patients on either buprenorphine or methadone who were also using stimulants. And I asked them what I could do to provide treatment for them to reduce their stimulant use. And most of them said, well, I don't need treatment because it's not a problem. And the ones where I probed and said, well, what about some counseling? I think 23 out of 25 said, 25 out of 25 said they weren't interested in counseling. So since that's the main thing we do to them when they're using, maybe we have to rethink that. And maybe we have to try to develop better treatments for them. So what do we have that works? Well, in the old days, if I was going to review effective treatments on a particular topic, I would have lots of bar charts and graphs and slides and show you data. But fortunately, in the last 3 years, we've had groups around the world doing these systematic reviews of big batches of literature. And for example, this is a study published in 2018. This is the earliest one I'll mention, where they looked at the comparative efficacy and acceptability of psychosocial interventions for individuals with cocaine and amphetamine addiction, a systematic review and a network meta-analysis. That is, they took studies, 50 studies with 7,000 participants looking at 12 different behavioral interventions. And they sifted through and they do a meta-analysis process, a very formal statistical process. What their result was, the combination of contingency management and community reinforcement approach was the most efficacious and most acceptable treatment, both in the short and the long term. They looked at CBT, they looked at 12-step facilitation, they looked at a whole variety of things. But their conclusions, and this conclusion is sort of rare in the field of meta-analyses. Usually meta-analyses say things like, well, nothing really worked better than anything else for everybody, but this might have worked better for these, and this might have worked better for those. This one was real direct: contingency management, community reinforcement approach. This was a review done by an Australian group, a very prestigious group, published in The Lancet, a very high prestige medical journal, on the data that the Australian group reviewed. Psychosocial interventions other than contingency management have weak and non-specific effect on stimulant problems, and there are no effective pharmacotherapies. So no medicines, and everything other than contingency management doesn't have much of an effect. So you get a second vote for contingency management. This one was done, published in 2020. They reviewed 44 studies. Their conclusions were, while contingency management intervention showed the strongest evidence, cognitive behavioral therapy showed some effect together with contingency management or without. So another one, contingency management. This is a study just published in 2021. Comparison treatments for cocaine use disorder among adults, systematic review and meta-analysis, 157 studies. Conclusion: contingency management programs were associated with reduction in cocaine use among adults. This one published in 2020, meta 27 studies on methamphetamine use disorder with contingency management. They looked at this range of outcomes. They found that in 26 of the 27 studies, contingency management reduced methamphetamine use. There was longer retention in treatment, more therapy sessions attended, higher use of other medical services, reductions in risky sexual behavior, and they felt better, more positive affect, less negative affect. Without question, this one was just published by my colleagues at the University of Vermont a couple of weeks ago. This is contingency management for patients receiving medication for opioid use disorder. That is people on buprenorphine and methadone who are using stimulants. What works? They looked at 1,400 reports. They found 74 that addressed this issue with 10,000 patients. They did their whole systematic analysis. Basically, what they found was contingency management was the only one that had treatment outcomes on these different measures. Reduced stimulants, actually cigarette use was reduced, opioid use was reduced, and you got better medication adherence to the buprenorphine or methadone. And you saw less other drug use and better therapy attendance. So this one was a little more detailed meta-analysis. Clearly, contingency management has all the chips. I don't say that these groups around the world, all looking at different sets of information, say the same thing. What is contingency management? It's a technique that involves the systematic delivery of positive reinforcement for desired behaviors. For example, in the treatment of methamphetamine dependence, vouchers, prizes, gift cards can be earned for giving methamphetamine-free urine samples, or you can use it to reinforce attendance at treatment. People actually earn stuff through their behavior, most often through negative urine samples. In most contingency management protocols, as people give more consecutive negative urines, the amount they earn goes up. So they might get $5 for a negative sample to start, but if they give 3 in a row, the value goes up to $10 per negative sample, and it can keep going up. In general, these in the research studies, the amounts we're talking about are $500 to $600 that they can earn over 12 to 16 weeks. So it's a significant amount they can earn. You're not going to change methamphetamine use behavior by giving people candy bars or checks on a sheet. The incentive has to be significant. And you have to have a behavior you can measure. That's why urinalysis results are a good target behavior. You can measure them. It's a yes or no. Or if they attend a session, yes or no. Changing their attitudes, changing all that doesn't really work. You've got to use something where you can measure the behavior and deliver the reward right away, immediately. You can't say, okay, you gave a drug-free urine today, next Thursday, you're going to get your reward. So it requires using point of care tests to be able to use this technique. Okay, you've got all this evidence saying contingency management is what works. No question about it. All the scientists agree. Why isn't it being used? Well, for a long time, the resistance around, and this literature's been around for 30 years. For a long time, there was this resistance in the field that, well, we really shouldn't be giving people rewards. It's not really right. They should be doing this out of their own motivation. Well, I tell you what, after you do this for 30 or 40 years, if you find something that works, you start to become less worried about whether it's the way you want it to be or whether you're going to use something that works. This works. That attitudinal stuff seems to be fading into the background. But there are two big problems. One is, where do you get the money to do this? And currently, SAMHSA has some real limits on how much you can use. And those limits are based on a misreading of Medicaid regulations that people think limit it to $75 per patient. That has been clarified by the Office of the Inspector General in a document they published last year in December. And in this document, they say there is no $75 limit on contingency management. And so if that's one of the assumptions you've had, that if you're going to use contingency management, you can only use $75 because you don't want to, violate Medicaid regulations. This is literally taken right from the final rule, this quote. There is no $75 limit. Now, you do have to track the incentives closely and have an accounting system, and only certain people can distribute the incentives, and it's as a security procedure, and you've got fraud prevention strategies. But this perception that there was a $75 limit has really been a problem, but that's now gone away. The thing that's now the biggest problem is SAMHSA has limits of $75. I'm working with a group that is trying to get SAMHSA to change that policy. We're talking to the new SAMHSA director, and we're hoping to get it changed. California just announced they're going to do full, $500 to $600 contingency management for methamphetamine use disorder. They're working with the Center for Medicaid and Medicare to make that work. These are some things you can take a look at as to what you can do, what you can't do. This all comes directly from this Office of the Inspector General final rule. But hopefully this is going to reduce the this non-use of contingency management. I spent my career, I did a lot of work on methadone and buprenorphine and opioid medications, and I did a lot of work on cognitive behavioral therapy and motivational interviewing. I wrote something called the Matrix Model, and I believe in all those things are very helpful, and they're all contributions. However, for treating people with stimulant use disorder, nothing comes close to contingency management as being effective. I'm sure there are neurobiological reasons for that. When they're in this anhedonic state, if you give them a reward, something tangible, something that means something to them, like a $10 subway coupon, or it matters, that it somehow rings the bell in their head. And so contingency management really is a powerful technique that we have to find a way to get it used. Because until we find medications, everything else that we've done in the way of treatment has had very poor outcomes. One other thing that I did a study on, I finished just before I left UCLA, was on exercise. We did a study, people in residential care, long-term residential care. Half of them got 3 times a week exercise for 8 weeks. Half of them got an education class as a control group. Exercise did a bunch of good stuff. Helped their physical conditioning, obviously, affected their heart rate variability, important cardiac measure, reduced anxiety and depression, reduced craving. We did PET scans on them. It helped their brain recover more quickly. And when they finished the residential treatment, they relapsed at a lower rate if they had been in the exercise group than in the non-exercise group. So we think exercise could be useful as part of treatment. And I've got a bunch of projects around the country that are trying this now. The trick is, how do you get them to exercise? So that's, I don't think that's unique to people with stimulant use disorder, but it's a challenge. Medications, very quickly. We have no medications approved by the FDA for the treatment of stimulant use disorder. These are some of the ones that are currently being considered promising for the treatment of individuals with cocaine use disorder. Mixed studies, some positive, some negative, nothing that is anybody's writing home about right now. With methamphetamine, there have been 2 medications. Mirtazapine has had 2 double-blind trials for individuals with methamphetamine use disorder that have been positive. It's an antidepressant called Remeron. Although when you talk to clinicians, and I know some of you may have tried this with your patients, it's not like giving a person with opioid use disorder a dose of buprenorphine. It's not like they feel better and go, oh boy, that's so much better. They may get a little bit of benefit from it, but it does have some evidence. The other one, that's the one that had all the headlines a few weeks ago, a couple months ago now, is bupropion naltrexone. That is Vivitrol combined with Wellbutrin in a combination. A large-scale trial funded by NIDA, 400 patients, multi-site, big science around it, published in New England Journal of Medicine, top medical journal in the world. They got a positive finding. Basically, what they're finding is that 1 person in 8 who got the medicine showed a positive result. 0 in 8 who had placebo got a positive result. So yes, it was statistically significant. Is that clinically meaningful? It's hard to say. It certainly wasn't, it wasn't a very large effect, but it's considered promising. That's where we are with medications. This is a study published last year. This says this is for people on opioid use medications, on buprenorphine and methadone. Can you give them a medicine to reduce their meth use? This says there's no strong evidence that any medication was effective in increasing abstinence, reducing use, or improving retention. So the discussion of medications pretty much across the board is we're still looking. A couple of things may be promising, but when you look at the whole big picture, we got to get contingency management used. It's the thing we know that works. We just haven't been very effective in getting it into application. In part because there was this belief that there's a $75 limit, and there currently still is a $75 limit on with the use of SAMHSA money, the SOR grants, the block grant. I had a number of groups in different states ask me to help them put together something for treating people with stimulant use disorder until we can get adequate levels of funding for real contingency management. So my colleagues and I put together a package of stuff that we call TRUST. It involves the $75 incentive that you can use. It involves CBT, community reinforcement, motivational interviewing, and physical exercise. We put it into a protocol, a 12-week protocol. There's my email. I'm happy to send it to you. No charge, no obligation. If you find it useful, great. But it's just some things that we've been using with a number of places around the country. And I have run out of time, and I think I've got about 8 minutes for questions.
Thank you, Dr. Rawson. That was fantastic. And I know that those last slides went away really quickly, but I just want to remind everyone that you can access this PowerPoint and resources on the MAT website at the conclusion of the conference. So I really appreciate your talk. We do have some wonderful questions that I'd like to get to.
Christina, could I say something before I go to the questions?
Sure.
Because you have such a high proportion of American Indian Alaskan Natives in Alaska, you should be aware that a researcher named Mike McDonald at Washington State University has created a protocol using contingency management for American Indian Alaskan Natives. He's worked with a couple of the tribes in Montana and South Dakota. He published an article in JAMA, very high deal, and it's specifically designed to allow contingency management to be used in tribal communities. And so I wanted to make sure I mentioned that because I think it's a very positive development.
Thank you. Would you mind just saying his name again?
It's Michael McDonell, McDonnell, and he's at Washington State University in Spokane.
Thank you so much. I appreciate that. The slides will actually be available on the conference website after today's programming. Oh, hopefully everyone can see that. There's a link in the chat to access the slides, and we can particularly go back and look at some of your last comments on the model. You talked about the trust model. That is wonderful, and we definitely want to look at that and spend a little time with it. So I'm going to ask a couple of questions, if I may, and I want to kind of start at some of the recent questions that had to do with some of your last content on contingency management. A couple of folks mentioned that they were concerned that monetary incentives might be a trigger, and there were some suggestions of using gift cards, Fred Meyer's for food, gas, those types of things. Would you support that?
Yeah, absolutely. It's a great point. Cash is a trigger. In fact, we're doing Mike and I are doing a project in Montana right now, and he's using something called Tango, which is an electronic gift card, and it actually send the money, it goes on the electronic gift card, and it actually is restricted. You can't buy alcohol or tobacco with the gift card. So it does sort of hopefully direct people in a better use of their money. But that's a great point. It's giving them cash is often counterproductive. It'll trigger a relapse.
Okay, thank you. And thanks to Carly, Kim, Jennifer, and Sarah for that discussion in the chat. I also want to appreciate the harm reduction strategies for those who use stimulants, the immediate positive reinforcer. And I know that many of us will go back and look carefully through those slides. I want to ask a question, if I may, from the beginning of the chat from Dr. Eliza Rose. She asked actually two questions. One, she's a pediatrician who's prescribing meds for ADHD, and her question, if I could paraphrase it, is does that have a lasting impact, or are there any concerns about later stage issues with stimulants and addiction? And additionally, she asked if there are any online de-escalation trainings that you might be able to recommend for some of that acute psychosis symptomology.
Right. And the first one I can answer, that's been looked at very carefully, because even going back to the earlier methamphetamine epidemic, that's the question that doctors have asked about. Well, hold it, if meth is doing all this terrible stuff to your brain, I'm writing prescriptions for Ritalin and other forms of amphetamine-like drugs. Am I going to be damaging these? No, if people have ADHD and medications are given in the proper dose for an appropriate diagnosis, you reduce the chances of later drug use. You reduce the risk of adult drug use, and there is no damage to the drug. It's therapeutic to the brain, because these are people who have a disorder where, for whatever reason, genetic or otherwise, they don't have adequate neurochemistry, and the medication helps to bring it up to normal levels of functioning. So it's not the same as if somebody goes out and buys a big wallop of methamphetamine and smokes it and causes this huge dose in their brain to cause brain damage. It's very different. But there is the issue of, do they have ADHD? And making sure the diagnosis is correct. There is a lot here in Vermont. When the doctors I've talked to in primary care are saying many adults come to them in November and December and January complaining of adult attention deficit disorder, and they want Vyvanse and they want Ritalin. And the question is whether these are real ADHD, or if it's like, gee, it's dark and it's depressing and I want something to make it better. And so there is like the legitimate and appropriate use for true ADHD. And then can be drug seeking for stimulants from doctors, where they go, as a kid, I had ADHD. I'm sure I'm 30 years old now, but I still got ADHD and I need some. So there's that issue. But if you're treating particularly youth appropriately diagnosed, then it's a plus, not a risk. The issue of de-escalation, it's the first time I've been asked that question. and I don't know of any, but I've talked with some of the emergency room doctors who in California, and I'll try to get you something. And since I know I'm not going to be able to answer all the questions, Christina, if you send those to me, I will answer them over email, and you can distribute the answers to everybody so that I get to answer all the questions, not just these few, because I took too much time.
Thank you. We will do that. We really appreciate it. And there are, as I said, a number of questions. We could probably listen all day. You have so many powerful messages. One that I would just like to, I wrote this down because I thought it was really impactful, which is if you kick them out of treatment, they're likely to get dead. These drugs are so lethal currently. And I really think that that is such a stepping stone for us to think about how to create an environment that is supportive, non-judgmental, and prepared for the high likelihood that some folks will experience some significant symptoms that may not be comfortable or safe sometimes for us as providers. So preparation for that is so critical. We have a lot of compliments and thank yous in the chat, and I would really like to extend that appreciation to you, Dr. Ross, and we have well wishes for the puppies.
Yeah, actually, I got her. She had parvo, which is a dangerous illness for puppies, but she's I think recovered, and now and I also adopted her mother because the mother did, and so she and the mother are that was the wrestling around you heard in the background.
Well, it's just so heartwarming, and we just greatly appreciate you. You have so much to say and so many messages. We will send you questions and appreciate.
Yep, I'll answer them and turn them around.
Thank you so much, Dr. Ross.
Okay.
All right.
Bye-bye.
Have a great day. Thank you. So if you will look to your screen, you'll see our agenda for this morning. And I would like to next welcome our next presenter, Dr. Weimer. I'll do a brief introduction. The title of this session is Understanding and Assessing Opioid Use Disorder in Patients with Pain. Dr. Melissa Weimer is a board-certified internal medicine and addiction medicine, is board certified, and is an assistant professor of medicine at Yale University School of Medicine. At Yale, she also serves as the medical director of the Yale Addiction Medicine Consult Service and associate program director of the Addiction Medicine Fellowship Program. Dr. Weimer has a clinical and research focus on expanding access to treatment for patients with substance use disorders, particularly in the hospital setting. She also has fellowship training and years of experience in the management of complex pain, particularly for patients with comorbid opioid use disorders. So I would like to take a moment and thank you so much, Dr. Weimer, for joining us. And we very much look forward to your presentation. And I will put myself on mute and please proceed at your leisure.
Thank you. Thank you for inviting me to speak with you today. I will be talking about treating patients with opioid use disorder and chronic pain. This is something that I've spent about the last 10 years trying to better understand and refine in the treatment that I provide as a general internist and addiction medicine specialist. So I hope that from this talk, you'll be able to have some really practical understanding of how to address this for the patients that you are seeing, recognizing that it can be a complex task and something that we really need to do well, given the fact that we have many patients who have chronic pain that can be challenging to treat, and that we are concerned about potential risks of using opioids for pain, but also recognizing that we can probably do a better job than what we have been doing. So at the conclusion of this activity, I hope that you will be able to have a better understanding and describe some of what we know about the neurobiological framework for patients with chronic pain and opioid use disorder, identify some key risk factors and features of opioid use disorder in patients who have pain, and describe some common approaches to safely and effectively treat both pain and opioid use disorder. So let's talk a little bit about the complex overlap that can occur when patients have both pain and opioid use disorder. So as we've traditionally thought about pain, we think of it as a sensory problem, something that occurs within your sensory system. And with difficult to treat pain, we recognize that you have increase in the sensory signaling. What we don't know as much about is what happens when pain persists, and how do those sensory systems perhaps interact with other complex systems in the brain, because we know that pain both has peripheral and central activity. And what we've started to better recognize is that when pain goes from being subacute or acute to chronic, there actually can be increase in emotion and reward. So reward learning processes can actually contribute to persistence and amplification of pain. So if we look at fMRI data of people who have subacute back pain compared to patients who have chronic back pain, we see that those with subacute back pain, really that sensory pain is what's driving a lot of their pain experience, and to a lesser extent, emotion and reward. However, as pain becomes more chronic in nature, you can see that the sensory systems of pain actually become diminished compared to the effect of emotion and reward. So as pain becomes more persistent, there is a complex interaction that's occurring within these other parts of the brain, which could be contributing to what can make pain become difficult, as well as how we need to really better address pain, not just from a sensory perspective. What's also interesting to think about is when you think about the effect of patients who have persistent pain who are also receiving opioids, and how the effects of opioids can contribute to these systems as well, because we know that there are potential effects on the reward system for better or worse in patients who are receiving long-term opioid therapy. We also see that with persistent pain, there are many other secondary problems that can occur that can facilitate distress and pain. Some of those are listed here. You can see that they can amplify or worsen pain, such as anxiety, depression, PTSD, cognitive distortions, stresses, functional disabilities. Substance use, if it's occurring, can worsen and facilitate pain. And as a chronic issue, opioid use disorder similarly has many of the same facilitators that can worsen the disease of opioid use disorder. So together, the two actually share many of the same facilitators, and when they occur together, they can reinforce each other. I think it's also important to recognize that 75 to 80% of patients who have an opioid use disorder have an underlying pain condition as well, whether that's primary pain or secondary pain from the consequences of their opioid use disorder, which we will discuss a little bit later. But it's just important to recognize that when the two coexist, they can be facilitated and reinforced by all these other various factors. And so to address them successfully, you really need to be able to address both of them, both pain and opioid use disorder. However, I'm going to say that in my clinical experience, if I have attempted to treat pain in the absence of treating opioid use disorder, I've never been successful. So it's really important that if you do have a patient who has both pain and opioid use disorder, in my experience, you really have to be able to address the opioid use disorder successfully in order to have the pain better treated, successfully treated. So I would be remiss to not help us understand, though, very, very clearly from the beginning that having an opioid use disorder and having physical dependence or tolerance on opioids are not the same thing. And this is a really, really key thing for you to remember and understand. So remember that if we prescribe a opioid to a patient for a long enough period of time at a high enough dose, that could be 30 milligrams of morphine for 1 week period of time. That could be a sufficient amount of time for that patient to go on to develop physical dependence and tolerance to opioids. That is a physiologic adaptation that occurs to the prescription of the opioid. And as I said, this can occur in a very short amount of time. This can occur with postoperative pain management, which takes many people by surprise. So it's just really, really important to recognize that that is a side effect of the prescription of the medication. That physical dependence and tolerance that occurs is totally different from the disease of opioid use disorder, which is a maladaptive behavior that's associated from the misuse of opioids, the development of the complex medical condition that is opioid use disorder or addiction with opioids. So very, very important key principle to recognize when you're treating patients who have pain, who are prescribed opioids. That person having a physical dependence and tolerance is very, very different, not the same, not synonymous with opioid use disorder. So it's important that you recognize those key differences. Now, I just went on a long time to talk to you about how they're very different. That being said, those patients who are prescribed these medications for a long period of time at a high enough dose can actually start to develop real complex physical and psychological states that actually can very closely mimic addiction. And this was well described in this commentary from Jane Ballantyne and others in Archives of Internal Medicine in 2012. And they describe it as dependence on opioid pain treatment is not, as we once believed, easily reversible. So that physical dependence and tolerance that occurs does not always easily reverse, particularly if somebody's been using these, prescribed these medications for a long enough period of time. It is a complex physical and psychological state that may require therapy similar to addiction treatment, i.e. opioid use disorder treatment. Whether or not it's called addiction, complex persistent opioid dependence, meaning physical dependence, is a serious consequence of long-term pain therapy. So the key difference here that she's trying to make is that when we prescribe these medications for a long enough period of time at a high enough dose, that complex physical dependence that can occur can start to mimic some of the features that we see in patients who have opioid use disorder. And we're going to talk a little bit about why that is, but just important to recognize that some of the patients you could be seeing, if you're treating patients who have pain in the primary care setting or specialty setting, may actually have features that are best described as this complex persistent opioid dependence, given the long-term relationship they've had with prescription opioids. But really, when we're talking about who has an opioid use disorder and who does not have an opioid use disorder, when we're talking about the treatment of pain, it's important to recognize there's this really big gray zone of those people who clearly meet criteria for an opioid use disorder and those people who do not. And I think that's just another important concept to recognize, is that we may not easily be able to determine who has an opioid use disorder and who does not. And there could be a lot of people who really exist in this gray zone, particularly those people who have been prescribed opioids for a long period of time. As we have better understood opioid use disorder and pain, we've also started to recognize that there could be some features of pain relief that actually mimic some of the behaviors that we see with opioid use disorder. And so, as you see here, you see highlighted the reward system in the brain, which is noticed here by the VTA to the nucleus accumbens to the frontal cortex. And so that we see with pain relief seeking, the desire to have relief from chronic pain or acute pain, like the seeking of an addictive substance such as an opioid, tobacco, alcohol, can actually, that seeking of relief can actually activate the reward pathway through dopamine and dopamine neurotransmitters and receptors. Over time, pain relief seeking behaviors can start to mimic substance use disorder. So if you are primarily focused on the behavior of pain relief seeking, that can actually start to look paramount to any other behavior, any other normal behavior within life. So as we talked about before, if we add opioids to a brain which already has inherently activated dopamine from the desire for reward seeking, that can cause this imbalanced reward system, which can facilitate opioid use disorder in some patients. So this is that complex interaction that's occurring where not only opioid seeking, but pain relief seeking can activate the reward system and can start to have some of the behaviors that we see within patients who have opioid use disorder. So, some of the reward transmitters that are implicated in substance use disorder. So if we think about opioid use disorder and we think about how there are different neurotransmitters that are increased in the reward pathway when someone has an opioid use disorder, we see that after use of an opioid, there's an increase of dopamine, opioid peptides, serotonin, and GABA. All of these different neurotransmitters lead to the idea of that positive hedonic effect, the quote, euphoria or feel good effect. Unfortunately, there's this negative hedonic effect that occurs when that person goes into withdrawal from opioids. And that is experienced with a dramatic reduction of dopamine, which feels like dysphoria. There's a reduction of opioid peptides, which causes pain. There was a reduction of serotonin, which also causes dysphoria. And there was a reduction of GABA, which can cause anxiety and panic attacks. So this can, again, facilitate that negative feeling of the absence of pain relief, the absence of opioid, and in a person who has both disorders, that can facilitate the feeling of worsening pain and dysphoria. You can see here how this occurs in a patient who is prescribed a short-acting opioid. So you can see that when you take the opioid, you have an increase in comfort or the analgesic effect. But as the opioid effect wears off, you can have withdrawal-mediated pain. We saw that with the dramatic reduction of dopamine, the opioid effect, the serotonin, all of those factors. That's when the person would then use another opioid to then have more comfort. And so they're going through this repeated cycle of worsening pain, withdrawal, which really is not a good way to live your life. We also know that once someone develops an opioid use disorder, other sort of addiction, that you can have what George Koob and others have described as the dark side of addiction. And this is the unfortunate situation that occur where over time, the more you have that excitation of the reward pathway, you can actually start to have an increase in what we call anti-reward neurotransmitters. And these are neurotransmitters that get increased when there is lack of that substance or lack of that pain relief. This can be felt as an increase of dynorphin, which again increases that feeling of dysphoria, increase of corticotropin releasing factor, which increases stress, increase of norepinephrine, which causes stress. And these all get activated when there is the lack of that substance in the system. So again, all of these, not only negative the neurotransmitters that get facilitated and in reward, but also the increase of these anti-reward neurotransmitters all combining together for the patient to feel very, very low, negative, painful, and dysphoric. So which patients with chronic pain are at most risk to develop opioid use disorder? So I've listed some of the patient-related risk factors for the development of both overdose and addiction here. You can see that there are several. We see that patients who have mental health disorders, substance use disorders are both at risk for overdose and addiction. Family history of substance use disorder puts someone at more risk for misuse and addiction. Adolescents have higher risk for addiction. Older age puts you at more at risk of overdose. Sleep disorder breathing, higher risk of overdose. Legal history of sexual abuse, increased risk of misuse. And then having a prior history of overdose puts you at risk of overdose as well. The different medication-related risk factors are high dose of opioids, greater than 100 milligrams of morphine equivalents, longer use of opioids, greater than 3 months, puts you at risk for both overdose and addiction. And then overdose risks are for patients who have the extended-release long-acting opioid formulation, in the initial 2 weeks after starting an opioid, and then the combination of opioids and benzodiazepines puts patients at risk for overdose. So how many of our patients who are prescribed opioids do we think go on to develop misuse or addiction? And from a systematic review of 38 studies, 26% in primary care, 53% in pain clinics, we see that the rates, as best we understand, are somewhere between 21 to 29% for misuse, which is defined as, the contrary use of the prescribed, use contrary to the prescribed for its contrary to its use, and then regardless of the presence or absence of harm or adverse effects. And then addiction, the rates that we understand are somewhere between 8 to 12%. And this meaning that pattern of continued use despite harms. So how do we evaluate for an opioid use disorder in patients who have pain? And for this, we're going to have a video here that hopefully someone else is going to be able to bring up.
So let me just summarize what you've told me so far. And so it sounds like you were injured playing basketball about a year ago and you had surgery, and you've been having shoulder pain since that time, and your doctor has been prescribing oxycodone 20 milligrams. Can you tell me how you've been taking the medication for your pain?
Sure. I mean, I'm supposed to take it 5 times a day, but sometimes I have to take it more than I'm supposed to, because of my shoulder.
Okay. So in preparation for this visit, which is what I do for all my patients, I checked the State Prescription Drug Monitoring Program, which is an online program that allows me to review, your medication list, where you've been getting medications and from whom. And it seems like over the last few months, you've been getting, more and more prescriptions from many different doctors, and that's concerning. Can you tell me about it?
I mean, yeah, I've gone to lots of different doctors because no one believes I really have pain. And I'll go to someone and they'll give me a couple pills and then I run out. And, I have friends who can get tons of these medicines, and I really don't understand what the huge deal is.
Yeah, no, so it sounds like you're spending a lot of time and effort to get these medications. It's been tough for you, huh?
I mean, yeah, I hurt my shoulder and then I had my shoulder surgery, and I guess originally were taking the oxys to help with my pain. And then I was able to do things like I could go to work and, do stuff with my friends. And, but then I guess I kind of was taking them more, because they made me feel good and, they gave me energy. But then the guy who did my shoulder, he just like stopped giving them to me, and I ran out and I got sick. I mean, I got really sick. And I was throwing up and I just felt so crappy. And I hated feeling like that. And so I went to my old doctor and she gave me, some more of the medicine. And I guess I was taking, more than I was to kind of feel good or to feel okay. And, sometimes I'll get them from like a friend of a friend or something like that. But it's not like I'm getting them from a drug dealer or anything like that. But oh my gosh, I can't believe, I can't believe that this has all happened. It's just such a mess. It's such a
Wow.
mess.
No, but it actually sounds like you're spending a whole lot more time, more energy and focus on getting the pills than actually treating your pain. Is that right?
I mean, yeah, if I run out of them, if I don't have the oxys, then I feel just so sick and so crappy. And then I can't go to work. And, I have a really, really great job. And, I feel like I'm in jeopardy of maybe losing it. And that's super scary because if I lose my job, I can't, pay my bills or my rent. And I don't know what to do.
Sounds overwhelming, completely overwhelming.
I mean, it is overwhelming. It's, I feel like I don't have control. I feel like I'm out of control.
Yeah, and so, loss of control makes me worried that you've developed a new problem, namely addiction to these medications.
I do not have addiction. My older brother, he is the one with addiction. He, would steal from our parents and he, got kicked out of school because, he wasn't doing well and, he is the one with the problem, not me. We're total opposites, and I have my life together, and no.
Okay, so maybe it's not addiction. Maybe it's just your body's become physically dependent on these medications, and when you run out, you get sick. But addiction does run in families, and addiction can look very different in different individuals. And do you mind if I share with you why I'm concerned that you have an addiction?
I mean, okay, I'm still not convinced that I have addiction, and I'm really concerned about my shoulder pain. So
I understand that, and let me just reassure you that I'm not forgetting about your shoulder pain, and we're going to continue to work on that. But the addiction piece, it's you described this loss of control, and the fact that you've needed more and more pills over time, and it just seems to be escalating out of control. And also, you haven't been able to do all the stuff that you normally like to do, like work and pay your rent and spend time with your friends. And so it's getting in the way of that. And those are the things that make me worried about addiction.
Okay, I kind of hear where you're coming from, but I'm still not convinced that I have addiction. And, I'm really still concerned about this shoulder pain I have going on.
Yeah, no, I totally understand that you're concerned about your shoulder pain. And to be honest with you, the way you've been taking these medications, kind of, escalating your dose and then running out can actually make your pain worse. But, there are some options. So in terms of your shoulder pain, I think there are lots of different things that we can try to address your shoulder pain. But in terms of this other problem that I'm calling addiction, and it may not be a full-fledged addiction, but certainly if you continue down this road, it's going to become that way. And there are options, okay? And one option is to treat you with a medication called buprenorphine. And I'm a qualified buprenorphine prescriber, so I can actually offer that treatment to you. I mean, the key here is to kind of stabilize things for you and to get you safe and comfortable and out of this cycle where things are spiraling out of control.
I mean, yeah, it sounds like you're going to help me kind of figure out this pain thing and this other option I think I'm open to. So it sounds like an okay idea.
Okay. So at the end of the visit, I'm going to have you meet with my nurse who will educate you some more about the treatment options. And we might even want to consider referring you to a counselor, again, just to kind of get things back in order, get your life back under control. And, and then we'll be able to reevaluate your shoulder pain and see where we're at and see what needs to be done, okay?
Okay.
Awesome. Thank you. Let me re-screen share. Okay. So we had a nice chat in the chat box that was sort of going around, and people were talking about how they were impressed that this physician or clinician was listening to the patient using MI skills. And I think those are all fabulous key reflections to make. And I just want to put a plug out there for our upcoming scope of pain training, which will be in October. I forget the exact date, but I'm sure someone can put that in the chat box. I would encourage you all to attend if you want to get more information. The clinician in that video was Dr. Dan Alford. He's a professor of medicine at Boston University. He's one of my mentors. We've worked together for a long time and given a lot of the scope of pain trainings. And it's interesting how, a real key to doing this work well is what you all mentioned: listening, spending time, understanding the patient's situation, not being judgmental, all of the things that I would hope every clinician would really be working to refine their skills set to be able to do. But I think that's a key thing to remember. And the reason why I thought this video was a great video to show, to say that these are really a lot of the skills that go into this work are just sitting with the patient in what can be an uncomfortable situation, and instead of it being a bad conversation, really have it be a very productive, compassionate, empathetic conversation where you could really be making a huge difference in this person's life, them coming back to you for treatment as opposed to not coming to you anymore. So the other key thing that this clinician does was he really kind of focused on his role, which was to be a clinician, to use a risk-benefit framework when he was evaluating the risks of a treatment such as an opioid, as opposed to judging the patient for whatever their situation is, their pain, their chaotic life, whatever it may be. So really judging the opioid treatment, not the patient. So that is the role that you need to stay well grounded in anytime you're doing this work. We are not DEA agents. We are not police officers. We are not judges. Our role as a clinician is to really, listen, understand, be empathetic, non-judgmental, and help the patient get care for the condition that they have. So we talked a lot about this, but these are really the key principles of how you would initiate an evaluation for opioid use disorder. We need to normalize a process of a risk-benefit evaluation as part of universal precautions and good pain care. Our patients have stories to tell us. They have, history of trauma. They have complex pain. They have complex medical conditions. They have complex lives. We need to normalize the process, that it's important that we really understand that and are able to make a really thorough, thoughtful, comprehensive evaluation of their treatment, whether that's with opioids, without opioids, with non-medical treatments, whatever it may be. We need to 1,000% appreciate that there is huge fear and stigma associated with opioid use disorder in patients who have chronic pain. I don't know if any of you are on Twitter or Facebook or any of those things, but you only need to write something about opioids and pain and have, many people respond about how they are not able to access good pain care, how, there's so much stigma around seeking treatment for this complex problem. There's stigma for seeking treatment for opioid use disorder. There's stigma for seeking treatment for pain, and there's double stigma when you have both. And as we already said, many of our patients actually do struggle with both. So we need to acknowledge that. We need to sit with our patients and help them feel comfortable to really share what their concerns are and really come to a collaborative understanding of how it's best to treat them. So Part of this work is always best understanding what is going on with their chronic pain, confirm to the best of our ability, and describe the chronic pain condition. Are we able to provide a diagnosis? Is there further evaluation that could prove beneficial? Many of the patients I see have had and struggled with chronic pain for 20 plus years, and you would be surprised how many of them have never really had a clinician fully examine them, fully do a musculoskeletal exam, a neurologic exam, listen to their heart and lungs, evaluate them for diabetes, heart disease, peripheral vascular disease, all of these things which can contribute to pain. So it is very important that we're actually spending thoughtful time to evaluate the patient, better understand their pain, provide a diagnosis if possible. We really need to better understand their functional improvement. Have they had functional improvement with pain medication? Have they ever been on therapies that have helped? If they have had absence of functional improvements, then they really may not respond to opioids, and we need to think of other treatments. If there's been no functional benefit, does that mean they have a lack of opioid benefit? And so really, why would we be continuing opioids in that situation? We need to confirm and describe that appropriate treatment has been offered and failed. What treatments have they tried? What has worked? What hasn't worked? What non-medication treatments have they tried and failed? All of these are part of really better understanding your patient, their experience, and then helping understand how possibly, if there is an opioid use disorder, that may be contributing to many of the different factors here. So we need to assess for side effects, their relationship with their prior prescribers, any concerning behavior, their prescription history, their substance use history, and other concomitant psychosocial factors. So we do that through all of these various steps. So it is important as we're evaluating and providing a diagnosis, assessing for risk, that we are using objective measures such as a urine drug test. We do recommend that this is part of an evaluation. This will help confirm or evaluate for a substance use disorder. We don't hang our hat on this information, but it's part of a comprehensive evaluation. Obviously, always talking to your patient about why you're obtaining it, what you're going to do with that information, how you're going to help treat them. We need to be checking prescription drug monitoring programs. If you're able to look at other states, Alaska is a pretty big state, so your patients may or may not be going to other states, but I work and practice in Connecticut. My patients do go to other states, Massachusetts, New York, pretty frequently, so it's important for Rhode Island. It's important for me to be able to check those other PDMPs. Looking at old medical records to assess their prior medical care, talking to their previous prescriber if possible. There are some different screening tools we could use, but none of them are sort of gold standard. You can utilize them, but again, this would all be part of a comprehensive evaluation. Unfortunately, there's not one questionnaire that's going to be able to tell you if this person is too risky or has an opioid use disorder. It's really going to be part of a thoughtful evaluation. Some of the features, if you do suspect or you are concerned about an opioid use disorder, are going to be those listed here. So you would be seeing that your patient has inconsistent healthcare patterns, missed appointments, lack of engagement. There could be signs or symptoms of drug use. The patient could be showing up intoxicated. They could have history of a drug overdose. They could have track marks, other drug use signs. Emotional problems, psychiatric illness that doesn't appear to be improving. You could see signs of illicit drug use, problematic medication behavior. Their family could be concerned about their use. You could see functional stagnation, loss of roles. If the patient is engaged in a taper, they may have a lot of difficulty with this, though I would not say this is the one thing that I would say absolutely shows the patient has an opioid use disorder, because we already talked about that. Physical dependence can be a really challenging thing for patients to be able to address. So what you're really looking for is a pattern to develop to understand if this is something that has become more of a problem, the severity, and if you need to think about a differential diagnosis for some of these behaviors, which again, you are going to determine through your time spent with them, listening to them, helping understand their situation. You see listed here some different yellow to red flags. If your patient is requesting an increase of an opioid dose, that I would consider to be a yellow flag. If a patient's having pain, they are going to potentially wonder if going up on their dose is helpful. That's normal. Requesting a specific opioid by name does not, could be a sign that, they have a specific history with this medication, but that doesn't mean that they are, quote, drug seeking or have a problem. So going down the list, if your patient is not adherent to recommended therapies, they're running out early, they're changing therapies despite adverse effects. So they're asking you for an increase of their opioid dose, even though maybe they had a serious opioid overdose. That would be concerning. Deterioration in function at home, they're not working anymore, or they've severely reduced their hours. Not adherence to monitoring. They don't agree that, getting a urine drug test is something that is part of a universal precaution. They don't come in for their appointments, things like that. Certainly multiple lost or stolen opioid prescriptions or illegal activity would increase your concern. So we talked about these different questionnaires. Again, there's two listed here, the CALM and the STAR. They are unfortunately not diagnostic. You can use them. They can help you have sort of a framework to understand these risks, but really based on their self-report, they have limited utility. I don't use them in my practice, but again, if you're starting out to just do this work and you want to have some different questionnaires or framework to use, you could use these as a place to start. So we sort of discussed this. There's not one test or questionnaire that can confirm that your patient has a prescription opioid use disorder. The initial evaluation will provide the basis for your risk-benefit determination. The initial evaluation will place a focus not only on concerning behavior, but also on pain and pain care. Important to recognize that you can have pain and opioid use disorder. Treating pain with opioids in the setting of opioid use disorder is risky. Treating opioid use disorder without treating pain is also not likely to be effective. So ultimately, in any of this evaluation that you do, it's going to come down to making a diagnosis based on the history that you've obtained, your conversation with the patient, and then ultimately using the DSM-5 criteria for the diagnosis of opioid use disorder. So the DSM-5 criteria is listed here. The first two criteria, tolerance and withdrawal, we discussed that for a patient who is prescribed opioids and taking those medications as prescribed, these two factors would be expected as long as the patient is taking them as prescribed. So we would not utilize these as part of our criteria if we are prescribing these medications to a patient. However, if your patient is not prescribed these medications, is taking them borrowed from a friend, using illicit opioids, heroin, fentanyl analogs, something like that, that would be part of your criteria. 3, 4, and 5 are all synonymous with a loss of control. So your patient is using larger amounts of the substance, the opioid, for longer periods of time than they intended. They've been unable to cut down or control their use. They have increased time spent obtaining, using, or recovering from the substance. Then 7, 8, 9, 10, and 11 are all that the patient is continuing to use the substance despite negative consequences. So this would be that the person's not able to maintain their roles at work, home, or school, parenting, working, what have you. They're having social or interpersonal problems related to their substance use. They're reducing social, work, recreational activities. Really, their life is revolving around the substance. So obtaining the substance, using the substance, recovering from the use of the substance. They may be using in physically hazardous ways. This could be by driving while intoxicated, putting themselves at harm, in order to obtain the substance. This could be engaging in sex work and other types of activities in order to obtain the substance, physical or psychological harm related to the substance use. And then the last criteria being craving or the compulsion, so the desire to continually, a strong desire to continually use the substance despite harms. So with these 11 criteria, essentially, there's a questionnaire that you can utilize for the patient, and you provide them a diagnosis of a mild, moderate, or severe opioid use disorder based on the number of criteria that they fit for a 12-month period of time. So this is all in a 12 continuous month period of time. It's hard to remember all of that. So the other thing that you can remember are the 3 C's. So this would be a clinical syndrome that presents as loss of control, compulsive use, continued use despite harms. All of these are part of a worrisome behaviors that set up that pattern and severity of use. Remembering that addiction is a behavioral maladaptation and physical dependence is a physiologic adaptation. So simply being prescribed the medication and having physical dependence on the medication is not the same as addiction. So discussing possible opioid use disorder can be a stressful conversation to have, but it's important to have, and your patient's lives can depend on it. So if you are concerned that your patient has an opioid use disorder, you need to give specific and timely feedback on why their behaviors raise your concern for possible use disorder. So as you saw in that video, the clinician was providing direct feedback about his concern. He didn't do it in a judgmental way, but he really shared that he was concerned that the patient may have developed an addiction based on her continued use of the opioid. Remembering that patients can suffer from both pain and use disorder. Just because they have an opioid use disorder does not mean that they are not experiencing pain. It's important that we are also addressing pain as part of the treatment for an opioid use disorder. If you and your patient disagree that they have an opioid use disorder, you may need to agree to disagree with the patient. If the patient feels that opioids are indicated for their treatment, but you feel that the risks outweigh the benefit, then it is important that you help them understand that your concern for their possible opioid use disorder makes it so that you're not potentially able to prescribe them that medication under those circumstances. If you are prescribing a long-term opioid to this patient, you may need to think that the benefits no longer outweigh the risks if you feel that they do. And some language that you can use would be something to say as, I cannot responsibly continue prescribing opioids as I feel it would cause you more harm than good. This doesn't mean that you're not offering them treatment, though. We do have highly effective treatments for opioid use disorder. Those treatments do also treat pain. As in the video, you saw that Dr. Alford offered the patient buprenorphine, and he offered it at that time. He offered it at that visit. He didn't say you need to go somewhere else to get this treatment. He offered it in his clinic. So if you are prescribing opioids for long-term pain, you should be able to offer the treatment of buprenorphine for your patients who you feel have been harmed by that treatment. The SAMHSA regulations have recently changed so that all prescribers can provide buprenorphine in the office setting without doing additional training. Obviously, we recommend that you're getting additional training. And there are some wonderful trainings that were just developed by the American Society of Addiction Medicine. But all prescribers, this is my opinion, strong opinion, all prescribers should be able to effectively and safely treat opioid use disorder. We have effective treatments, and I would hope that you all are offering this in your setting if you are a prescriber. So we need to be offering this referral for treatment and medication treatment. These are the medication treatments that we can provide. They alleviate physical withdrawal. They provide opioid blockade. They alleviate drug craving, normalize brain changes. If you are using methadone for the treatment of opioid use disorder, recognize that this has to be dispensed in a licensed opioid treatment program only. I recognize that these clinics may be quite limited in Alaska. That is why I think buprenorphine as an alternative is a really good treatment that I hope that you are providing. Naltrexone, we're not usually using for patients who have pain because it's an opioid antagonist. However, you can use it in highly motivated patients, but generally, if I have a patient who has both opioid use disorder and pain, I'm generally thinking about utilizing buprenorphine, particularly if I'm treating them in my own office. We know that outcomes are improved when patients are receiving these treatments, both all-cause mortality, drug use-related mortality, retention and treatment, decreased recurrence of drug use, HIV and Hep C outcomes as well. There are some different formulations of buprenorphine that you can use, but recognize that these other formulations of buprenorphine, such as the transmucosal buprenorphine, the buccal buprenorphine, the transdermal patch, these are indicated for the treatment of pain, but if your patient has an opioid use disorder, we really are probably thinking about the use of the sublingual buprenorphine, utilizing it off-label for the treatment of chronic pain. But of course, if you're using it in a patient with opioid use disorder, then you're using it on-label. If your patient does have pain, you could be dosing the buprenorphine more frequently than we would for a patient who has only opioid use disorder, so utilizing it every 6 hours or 8 hours for pain. And there have been systematic reviews that show that buprenorphine is effective for the treatment of chronic pain as well. Recognizing that if you are using another medication on top of buprenorphine, which you can do for patients who have acute pain, you may need to use a higher dose of that medication. That's a bit beyond the scope of this talk. We actually will address that in the scope of pain talk, so I would encourage you, if you want more information about that, to attend there. So let's end with a case, and then we'll have time for questions. So this is a 35-year-old female with chronic daily migraine and diffuse myofascial pain who's been prescribed opioids for 5 years after the birth of her daughter. She has severe depression, anxiety, chronic nausea, history of adverse childhood experience. She was neglected as a child, and she has obesity. She's a stay-at-home mother of her 2 children, but frequently has to put the children in daycare because she cannot care for them from her severe migraine. She's also prescribed chronic high-dose benzodiazepines by a psychiatrist. The patient has a history of losing her opioid prescription, obtaining opioids from another prescriber, being allergic to most other pain treatments, missing appointments, and frequently asking for opioid dose increases. So some thought questions, given everything that we just went over. Do we think this patient has pain? Do we think this patient has an opioid use disorder? What factors place her at risk to have an opioid use disorder, and what can we do to help this patient? So moving on, while you're thinking about that, this patient undergoes a full opioid use disorder assessment and is determined to have a moderate opioid use disorder based on the following: failure to fulfill roles, continued use of opioids despite harms, time spent procuring the medication and craving. She's reluctant and scared to consider alternative treatments or seek opioid use disorder treatment, but is appreciative of the honest assessment of her condition. She would like to think about the idea. 2 weeks later, she makes an appointment to see you and seeks treatment for her opioid use disorder and agrees at that time that she does in fact have an opioid use disorder. 3 months after stabilizing and starting buprenorphine naloxone treatment, along with cognitive behavioral therapy, she says, quote, "Thank you so much for helping me. I am myself again. I am finally enjoying my life with my kids, and I'm thinking about starting a small business." So did this patient have pain, or does she have pain? Yes, she has chronic migraines. Does she have an opioid use disorder? Yes, she does. What factors placed her at risk? She had some different personality traits, young age, concomitant use of benzos, mental illness, adverse childhood experience. She had some medication non-adherence, lost prescriptions, compulsive use, and frequent bouts of opioid withdrawal from overuse of the medications, which were causing this negative effect of motivation and craving. So what can we do to help this patient? Well, we identified the underlying biopsychosocial factors that were contributing to her pain. We identified the neural processes that were contributing to her behavior. We guided her towards activities and treatment modalities that increased her recovery. We talked to her about limiting substances, tobacco, fast-acting analgesics, provided social reinforcement, problem-solving, effective emotional coping through the cognitive behavioral therapies that she was also getting. All of this helped her be able to set small goals and improve her quality of life. And we offered her safe and effective treatment by using buprenorphine for her pain and her opioid use disorder. So in conclusion, chronic pain and opioid use disorder share many common features that can motivate a person's behaviors. Diagnosing opioid use disorder during pain management requires a thorough evaluation. Typical substance use disorder factors probably apply to prescription opioid use disorder. Those are listed here. And managing opioid use disorder by quickly stabilizing and treating with buprenorphine or methadone can really improve people's quality of life and ultimately save their lives. So I highly encourage you to think about joining us for the Scope of Pain, which will be October 26th at 11 a.m. Alaska time. Myself and Dan Alford will be doing this presentation. It's a wonderful presentation. I would highly encourage you to attend. And for additional information, I would encourage you to check out the PCSS providers clinical support system, many free hours of education, well done education. And then there is a new 1-hour online training module that is available on the ASAM, the American Society of Addiction Medicine website that I've listed here. For those of you that are interested in getting more information about buprenorphine and potentially prescribing, and it's free, I would encourage you to attend, and I'm happy to take any questions.
Thank you so much, Dr. Weimer. Really appreciate your presentation. You had an awful lot to share, and I know that I'll be going back through and looking at the resources, your slides. We got a lot of compliments on the brief vignette that you showed, the video of the clinician who was doing a great job with his patient, using those motivational interviewing skills and being non-judgmental, but also very direct and honest. So I think that was refreshing, and I appreciate your comments about, wanting that patient or client to return. And I think that really underscored that sentiment. So there is a lot of thank yous. There are a lot of thank yous here in the chat, and there are a couple of questions I think we would have time for. I want to point out that there are a number of resources that have been listed here in the chat and will be available on the website later. So thank you for all of the activity in the chat. Lots of wonderful exchange. So we did have a question about, I wanted to ask, and you may have answered this, but if you have any other comments about an individual in long-term recovery who is prescribed medication following a surgery, and you mentioned, taking it as prescribed, and the question really goes to the high risk for addiction or relapse, I suppose, in that case. And you mentioned, taking it as prescribed, and certainly when you went through the criteria that is utilized to assess and diagnose for addiction, that those points definitely weren't present for someone in recovery who's utilizing prescriptions, but it definitely can be a cause for concern or worry. Any comments on that?
Sure. I mean, treating acute pain for patients who are in long-term remission or recovery can certainly be, say they're going through surgery or other types of acute painful conditions, can definitely be a time where we need to provide additional support and evaluate for potential relapse risk. One of the risks would be if we do change their treatment, such as their buprenorphine, if they're using that, or their methadone, it would be important that we are really thinking about how to get them stabilized back on those therapies. We are increasingly, and more people are now recommending as more standard of care, that patients who are prescribed buprenorphine are staying on that therapy, even in the setting of surgery. So I think we go over this in the scope of pain training as well, but essentially the idea that you can really highly destabilize somebody if you take them off of their medication, such as buprenorphine. So we're recommending that they're staying on buprenorphine and treating with full opioid agonists on top of that. And there's increasing literature and clinical guidelines that recommend that at this time. And I would say in my clinical practice, we are only doing that at this point in time because of the high risk to patients if we're taking them off that therapy. But yes, even patients who are in long-term recovery from alcohol use disorder in the setting of an acute pain, if they're prescribed opioids, that can also put them at risk for relapse. So I think it's just an important time that we're open and honest with people about the experience. There is so much shame that people have who are in, remission from their substance use disorder if they start to develop a problem with opioids for acute pain treatment. I think we just all need to be more open and honest about it being a challenging situation. And if they're struggling, we need to be able to support them and just, it shouldn't be so shameful, and that's part of what's driving the use is the shame. So the more we can just talk about it, be non-judgmental and really support them through it, the better outcomes seem to be.
Thank you for that. I appreciate that. And I appreciate the comments about the stigma. Definitely, that's something that's ongoing. I think we'll have this one more question, and I appreciate your comments about your upcoming The Scope of Pain workshop coming up next month. So I hope people are able to attend that. And I'm sorry I can't get to all the questions. So just this last question here before our lunch break. Isn't the body always, and this comes from Leslie Nelson, isn't the body always seeking homeostasis? If the level of pain and the amount of opiate don't even out, then does the body create more pain? Interesting question.
So yes, the body is always seeking homeostasis. I think the issue with long-term opioid use that it's a new evolving science, I would say, is that your allostatic set point or your homeostatic set point can actually change when you are exposed to long-term opioids. So because of that can actually drive more of the opioid use behavior. So this is a little bit beyond what this talk, but essentially just recognize that long-term use of opioids can actually change your homeostatic set point, and therapies such as methadone and buprenorphine can help stabilize that. So particularly if you have a patient who has developed opioid use disorder in the treatment of their long-term chronic pain treatment, these medications can actually become quite essential to restabilize that set point so that they're not having all of the dysphoria and other symptoms that come along with that imbalance. Hopefully that answered your question. I was trying to kind of distill down a lot of science into a very short answer. Sorry.
You did great. Thank you. And I know that was a big question. So I really appreciate it again, and thank you for your wonderful talk. Lots of information. So thank you for that.
Our next speaker is Dr. Sarah Spencer, and she will be presenting on engaging patients with severe opioid use disorder through low-threshold integrated care treatment. Dr. Sarah Spencer grew up in rural central Maine and did her medical training there during the peak of the original OxyContin epidemic. She's board certified in family and addiction medicine and has been providing treatment for opioid use disorder in rural Alaska for over a decade. Dr. Spencer works with Project Hope to provide opioid overdose response training and naloxone distribution, and is a founding member and volunteer medical director of Alaska's only rural syringe access program in Homer. She's currently an employee of the Ninilchik Traditional Council and provides family medicine and addiction treatment services at their tribal clinic, including telemedicine to remote Native villages. She teaches on addiction issues across the state of Alaska, including buprenorphine waiver certificate courses. She is a co-author of the state's medication-assisted treatment guide and is the state's senior physician consultant for the SAMHSA-funded Opioid Response Network nonprofit consulting program. Please join me in welcoming Dr. Spencer.
All right. Good to have join everyone today for this meeting. So today we're going to talk about how to better engage patients with severe opioid use disorder through making your practice more suited to them and offering them a better variety of services in your clinical practice through integrated care. So we're going to talk about making sure that patients can access their medications quickly when they come into your program, trying to make it easy for them to access psychosocial supports, and how to make sure they have access to services to reduce the harm that drug use causes. I don't have any financial disclosures. So I just have a quick poll. I'm interested to see where everyone's coming from today. What's your role in treating patients with substance use disorders or in working with patients with substance use disorders? Okay, looks like we have a good, pretty even spread across the board of quite a few different folks. So that's nice. Good chunk in the behavioral health, and then kind of pretty evenly spread otherwise, I think. Okay, good to know. All right. So what is integrated care? Integrated care just means sort of a general term for any attempt to provide some component of primary care, mental health services, and addiction treatment, any two out of the three or all three, kind of in any way. And it can be very basic or it can be very comprehensive. It's sort of whatever you want it to be. There's no set definition for what integrated care means. And what is low threshold care? Low threshold care really means recreating care to make it suited for patients who have the most severe substance use disorder. Patients who have severe substance use disorder, medical system as it currently exists, it's not accessible to them for the most part. They need it the most, and they can't get care generally the way it's set up. They generally don't have access to primary care. So we want to make sure that that patients can access care quickly, easily. It doesn't place a lot of demands on them. It's really the care is patient-centered, it's harm reduction focused, and to engage the most marginalized patients without putting a lot of demands on them. And it has good outcomes and good retention and treatment. And what we want to make sure is that no matter where patients present when they are ready for treatments, that they're able to get treatment quickly. Because again, most of these patients don't necessarily have a primary medical home, but so they could be anywhere. They could be in the emergency department, they could be in jail, they could be at the syringe access program. Whenever they decide that they need care and they're ready for care, or they're in a moment of crisis and they approach someone, and share that with them, that they're able to get pointed towards getting medical help, and that they're able to get that help right away. And we want to make those connections within the community so that they're able to get medications right away when they need that help. And that's not going to happen until we break down those silos within our community. So the first step, one of the most important things, is to make those connections within your community to connect with those places where the patients are. Because again, those patients aren't necessarily, I mean, some of those patients might be in your clinic, but a lot of the patients aren't. A lot of the patients, there are other places in your community. So making those connections and, sitting down and sharing with the jails and the child protective services and the shelters and your behavioral health clinics, what it is you do and how to get patients in with you quickly is really critical to make sure that when they have patients that present there that are in withdrawal, that need services, that are struggling, they're in crisis, that they know how to get them to you right away, so that you can all work together as a community to get patients the help that they need right away. And in order to practice low threshold care in your clinic, the first step is to correct any misconceptions that patients must achieve total abstinence in order for MAT to be considered effective. So defining success and recovery, it's not about abstinence. The true success and recovery, it's about quality of life, staying out of jail, improving your interpersonal relationships, improving your relationships with your family, being able to be there for your children, going to school, having a safe place to live, improving your physical health, and being able to contribute to your community and have a sense of purpose in life. That's really the point of treatment and recovery. Abstinence from drugs, that's nice. That's an objective point that we can quantify on a test, but that's not really the point that we're going for. We want to try to help people meet their goals and improve their quality of life. And everyone's goals are different. So we want to find out, what is that person's goal? If their goal is to stay out of jail, that's their goal. And we want to help them meet that goal and whatever it means to that person. And that may not include abstinence at all for that particular person, or it may. So patient-centered goals is critical when we're talking about low threshold care. Who could be team members in an integrated MAT team? These are potential team members. You may only have one of these team members. You may have all four. In our team, we're lucky that at the moment right now, we have sort of 3 out of 4 of these team members. I'm the medical provider. We don't have a psychiatrist. Right now we have a case manager who's also a peer support person, and we're lucky to have a behavioral health provider. Some places may only have a medical provider. Maybe they have an MA who also works as their case manager. They don't have a behavioral health provider, but maybe they can refer to a behavioral health, or so your team may look very different from this, and so there's no one right picture of what does your team look like. I would say and the medical provider may not even be there on site. It might be a telemedicine provider, which is totally fine. So not all of these people are all in the same place at the same time, but they still can work together at a team, even if they're not all in one place at one time. So let's talk about just briefly a few potential roles that some of these people can play. Now, these aren't all of the roles that all these people can play, nor are they all the roles that people have to play. These are a few examples of some things that at our clinic that we offer patients. I'd love for maybe share in the chat some of the things that you might offer some of your patients to try to reduce some of the barriers to care that you offer. So just to highlight a couple things that our case managers do. Number one, most critical thing is a cell phone, work cell phone, for after hours and text support. Our patients, they never answer their phone. They only communicate by text. I don't know what we would do if we didn't have availability to text with patients. Very assertive outreach to patients when they miss their appointments, to try to follow up with them, to get them to come in, the case manager. arranging intakes. So being, that her cell phone number is sort of just floating out there in the community. Anyone can call. So she gets calls, from the jail, from the emergency room, from any folks, that have gotten her number through the syringe access program saying, hey, I'm ready for treatment. Can I get in tomorrow? So arranging those rapid intakes from patients, kind of on the fly, is a big part of her role of what she does. And arranging transportation. Transportation is probably our biggest barrier. We're in a rural area. We're 35 miles from the nearest pharmacy at one of our main clinic site. So it's really difficult to get people to their appointments. So, and of course, a lot of times we're dealing with last minute appointments, walk-in appointments, same day appointments. So Medicaid travel tends to fall through. So we're dealing with gas cards or picking people up for their appointments or telemedicine, that sort of thing. So that a big part of her job is trying to arrange transportation. We recently added in video directly observed therapy services to help people monitor, showing us that they're able to take their medication, again, to try to overcome some of those barriers of not being able to make it into the office because of all the transportation barriers that they're dealing with. So our case manager does so much to help out to reduce those barriers and to try to actively get people into the office. Peer support or outreach workers, and these kind of there's a lot of overlap here. But again, they have a cell phone that patients can call and text, and they just need someone to talk to. Maybe they want to sit down and just have a cup of coffee and talk about some of the stressors they're going through. Maybe they're having cravings they want to talk about. Maybe they want someone to take them to an AA meeting or an NA meeting. They need a ride to go to a residential treatment, or they need someone to sit down and help them fill out applications for residential treatment. Our peer support people have helped to organize some recreational activities like beach cleanups or crafting groups, that sort of thing. Again, lots of different options for how a peer support person can assist and kind of helping out with case management too. A lot of overlap there. We're going to talk a lot about my role in medical and in the clinic, but being a lot of scheduling flexibility, allowing patients to come in for same day access. So kind of skip over this. We're going to talk about all of these things as we go through the presentation. Behavioral health, again, we're going to talk about all these as we go through the presentation, but trying to really be available at the same time that patients have their medical appointments, kind of for same day medical and behavioral health access. And also we've added in the last year some virtual and digital subscription options so that patients have the option to do some therapy options, through apps on their phone and that sort of thing, if they're not too keen on the idea of meeting with a counselor. Scheduling barriers. So I think when we're dealing with low threshold care, and you're in a busy primary care office, scheduling can be a huge issue. Patients who have severe substance use disorders, they really struggle to keep scheduled appointments. And it's really important to remember that trouble keeping scheduled appointments is a symptom of severe substance use disorder. Trouble with meeting expectations and obligations. That is a criteria, a DSM-5 criteria of the disease. It is to be expected. No-show rates for intake appointments, in studies have been shown to be 50% or more. You should expect that. That is normal. And you need to allow for that in the development of your program. And so one thing is to really trying to develop some open access scheduling to be built into your program. When you have, when people come in as walk-ins or really short appointments that are scheduled less than 48 hours in advance have much lower no-show rates than appointments that are scheduled farther out. So having that kind of scheduling can really help to reduce your no-show rates. And also having schedule blocks that are, blocks that are set that are the same every week. Like in our clinic, it's always every Tuesday and then every Thursday afternoon. Those are times that are strictly for MAT patients. And so it gives us that kind of open access flexibility that we can kind of move things around, and we have that flexibility for walk-in time. That's not going to conflict with our, annual physical or my CDL physical and those sorts of things with my family practice patients. At other times, that gives me a lot more flexibility to allow people to, they always know that on those days that there's some flexibility that they can walk in to get their medication refilled or to get their medication injections done. Another way that can help with scheduling issues are group visits, and we'll talk a little bit about that. It can help patients to know that there's a predictable schedule where they're always going to have the same appointment time, and also for providers to see more patients in a shorter period of time on a more predictable schedule that can kind of fit into a busy provider schedule. And in our practice, we always allow for walk-ins for monthly medication injections. And that's something too that can be done by a nurse or another provider that's been trained and is qualified to do medication injections once a patient is stable. Sometimes a patient, keeping them on their medication is the most important thing for reducing mortality. And so sometimes, even if I'm not available, or I'm only available for just a moment, in between patients, if the only thing I can do is just come in real quick, just in between patients, we'll get you your shot. I don't have time for a full visit, but, maybe I can get them their shot, and the case manager or someone can then, sit down and spend a little bit more time with them than I have, or spend some time with them over the phone, to get a little bit more history from them and spend that time that I might not have as the provider. Psychosocial support access. The ASAM 2020 guidelines state that psychosocial needs should be assessed, and patients should be offered or referred to psychosocial treatment based on their needs. However, a patient's decision to decline psychosocial treatment or the absence of available psychosocial treatment should not preclude or delay starting medications for opioid use disorder. And it's also important to remember that motivational interviewing can be used in the office to help address a patient's need and also help encourage them to engage further in treatment. So we want to encourage people to do psychosocial therapy, but if we don't have that available, or if patients aren't willing or able, it's okay. We don't want to withhold medication for that. And those are specific guidelines now. And psychosocial supports come in many different forms. It doesn't just mean counseling. There's so many different things. Of course, there are long-term, mutual support groups, so many good online support groups now that I think people have used a lot more with COVID lately. The peer support, which can be a really casual kind of one-on-one support that can be really meaningful to people. The motivational interviewing during medical appointments. And we've had patients say that was really meant the most to them, more than anything else. Patients say, I would never talk to a counselor. I hate talking to counselors, but they will just pour their heart out to you during their medical appointments, or to the peer support. So getting, if you haven't had training in motivational interviewing, or if your case manager or peer support hasn't had training, I highly recommend training in motivational interviewing, because that can make a huge difference in getting patients, to help them to develop their own treatment plans and getting them ready to make those changes. They have to be the ones to make those decisions in their life. So we'll talk a little bit about contingency management and group visits. So group visits is a really nice way to integrate behavioral health care into your office, and also make the scheduling a little bit easier in a busy office. So it can make increased collaboration between behavioral health and providers, give patients more of that behavioral health support, and kind of reduce some missed appointments and some burnout related to kind of overscheduling. So there's lots of different ways to do group visits. Typically, the time that they occur over is like a 60 to 90-minute period. They usually happen on a really schedule where it's always the same. It's either every 1 to 2 weeks. It's always the same day of the week at the same time. So it's very predictable to patients. They always know when it's going to be, so that they're much less likely to, forget or miss that appointment. And they'll check in initially if they need to do a urine drug screen or something, they can do that, or a pill count, they can do that when they check in. There is the behavioral health component, which is a facilitated group discussion. Part of that can be a therapeutic or educational or mutual support group discussion that can be led by can be a behavioral health professional like an LPC, but it also could be someone like it could be a behavioral health aide, it could be a peer support person who's led NA groups or AA groups in the past. There's no one person that would need to do that. There's lots of different options for who could be the facilitator for that kind of a group. But some kind of group person that could lead facilitated group discussion. And then either before or during that time, patients take turns to have very brief medical visit where they just come out just for 5 to 10 minutes to spend individually with a medical provider for a really quick check-in to say, like, hey, are you taking your medication? How did it go? How are your cravings? Do we need to change doses? Those just dealing with most urgent issues. And if there are refilling medication at the time, and then saying if there are urgent issues, or like saying, okay, you're not doing so well, you can always schedule another medical visit in between the group visits for patients who aren't doing that well, who need more intense medical care. But patients who are doing well, they may just need that really brief, medical visit. Over that time period of 60 to 90 minutes, these groups are generally include like about 4 to 8 patients. So the provider is able to have, a good number of patients they're able to see. The patients have that nice regular schedule that's easy for them to get into a routine of, and they're able to get that behavioral health support without going to an extra appointment. So it can kind of address multiple different barriers at the same time. Once COVID is over. Harm reduction. Annette Hubbard let me see these harm reduction slides. So harm reduction is an approach designed to reduce the harmful consequences associated with high risk activities, which could be really anything in life, driving, having sex, using drugs. There's lots of things we do in life that are associated with risk. And we're not trying to save anyone or rescue them. We're just trying to support them where they are without any judgments or assumptions. Is harm reduction enabling? It's the biggest thing that people worry about with harm reduction. So it's not enabling because people are already engaging in these behaviors, and they're not necessarily going to stop engaging in these behaviors. So they're already having sex, they're already driving fast, they're already using drugs. So it's not enabling, but it is enabling, and that's enabling people to keep themselves safer. It's enabling people to keep themselves healthier and to educate themselves and be honest and to learn about their own strengths and be more successful and healthier in life. So what is it that syringe access programs do? So they don't just provide safe syringe disposal and safer injection supplies and safe smoking supplies. They also provide education about issues on the street about like dangerous drug supplies. They provide testing for hepatitis C and HIV. They also provide, a support team for people, linkage to social services and treatment, and utilize clients that utilize syringe access programs are actually 5 times more likely to seek SUD treatment services. So it's a huge entry point for people to get into treatment for SUD. And in our clinic, our clinic is not associated with our local SAP, but we have 3 or 4 of people that work in our clinic have also at some point in time or are actively volunteer with our local syringe access programs. And they're a great place to provide treatment outreach services. It's a judgment-free environment where people can feel safe and respected, and patients who otherwise wouldn't have access to medical care. It allows you to develop a relationship in that safe space with someone, where you can have, build that relationship of a mutual trust and respect in that neutral setting. And over this last year, when we reviewed our records, almost half of our patients who have utilized our clinic services in the last year were referred in one way or another from our local syringe access program. So it's a huge entryway into treatment. So they're very, very important community health services. And again, when you volunteer at services like that, it really shows patients that you care about them, that you care about them whether they're using drugs or not using drugs, that you care equally about them, their health, no matter what's going on in their lives. Now, most rural communities in Alaska do not have syringe access programs. ANTHC has a mail-out harm reduction kit service. If you go to iknowmine.org, you can get information on this and order some kits that you can have to give out in your office. I would definitely encourage you to check that pilot program out. It is, they also have a really nice rural Alaskan harm reduction toolkit booklet that you can download that has a lot of really great information in it. So I would highly encourage you to check that out. A really underutilized tool as well is just writing a prescription for syringes so that people can order them online when they can't get them locally. And this is just an example of how you might write a prescription if you're not familiar with what kind of syringes people would need. And if you are not a member of the Project Hope distribution program, you should definitely sign up for it. Contact Project Hope so that you can have the Narcan kits in your office, so that when you have a new client who comes in who has an SUD, and it's not just for people with opioid use disorder. We know that methamphetamines are often contaminated with fentanyl, as are other drugs. There's a lot of counterfeit benzodiazepines that are contaminated with fentanyl. And so, having Narcan available to hand out to patients, clients right there when you see them is really important. So I highly encourage you to sign up with Project Hope to have these to hand out in your office. Let's talk about immediate access to medication for opioid use disorder. So again, updates to the ACAM 2020 guidelines. A comprehensive assessment of the patient is important for long-term treatment planning. However, completion of all of the components of the assessment should not delay starting medication. So we need to medically stabilize the patient with medication, and then we can kind of finish completing, all of the components of the treatment. The lab testing and all the complete physical and the complete, psychological assessment, and all those other little parts that might go along with our complete assessment. The stabilizing the patient medically first is the most important thing. And a good example of that is starting buprenorphine in the emergency room. So this started being done about 5 years ago nationwide, and now it is the standard of care. It has become the standard of care among emergency rooms. Now, most emergency rooms in Alaska are offering it. It's not 100%. It's kind of still a little provider specific, but starting buprenorphine in the emergency room doubles the chance that patients are going to be in treatment at 30 days, cuts in half the chance that they're going to go back to the emergency room, cuts down by 2/3 the chance that they're going to need an SUD admission, and it greatly reduces healthcare healthcare costs. So it's very effective, and it is now the standard of care to start that in the emergency room. And so they start in the emergency room, and they can treat patients for up to 3 days in the emergency room to kind of bridge them until they can get that care in the office. But then again, they need to be able to get into the office quickly to continue that care. So your clinic really needs to have a plan in place that when you have a patient who's referred from the emergency room, say, hey, say the patient got out of jail on a Friday night, they went to the emergency room, they got started on buprenorphine. Now it's Monday morning and they call and say, hey, I just got my last of my three daily doses from the emergency room. I can't get any more. They told me to call you to get in. You need to have a plan in place for rapid intake of patients to be able to continue without interruption that medication, which is so important to reduce mortality. Nationwide, they've studied in the emergency rooms. This study just came out last month. That's why I threw this in here. I just saw it in my mail today, that even in rural emergency rooms, they found that over the last year, that they tripled the number of patients that were diagnosed with opioid use disorder, and they tripled the number of patients that were treated with opioid use disorder by offering this low threshold initiation of buprenorphine in the emergency room. So it's really dramatically increased access to treatment of opioid use disorder by starting it in the emergency room. So the ultimate low threshold. The other thing they're looking at in California, going along with the same program in California, is actually starting injectable buprenorphine in the emergency room. So again, really looking at that ultimate kind of low thresholds care of starting medication as soon as possible, right there when you can, when the patient is in that crisis moment. The other issue with starting medication right away is the place where to start it. So when you're talking about low threshold care, traditionally in the past, 10 years ago when I first was treating people with buprenorphine, we were taught that you were supposed to bring people into the office. First you had to have the person meet the person a couple times, and then you had to have them come in withdrawal, and then you had to come in for dosing every hour, and then you had to have them come in every day. And it ended up being like a 5 or 6 visits to before someone was finally on their dose of buprenorphine. And that is just really unrealistic, especially a person with severe substance use disorder, and especially when you live in a rural area like we do, and patients know, my patients, they lost their license, they don't have a car, and then to have them try to time their withdrawal with they can't even make their appointment in the first place. They can't even make one appointment. So, office-based induction really isn't realistic for the most part for these patients. So, home-based initiation of buprenorphine is considered safe and effective now, and it's officially on the ACM 2020 guidelines, so you can feel good about doing it. So when you do home-based initiation of buprenorphine, when the person comes in for their first visit, you're going to do that assessment, diagnosis, go over the options with them. If the patient and you choose to start them on buprenorphine, you're going to give them instructions on how to take the medication, some kind of written instructions as well, so they can kind of remember when they go home, if they're not already familiar with how to take it. A lot of patients are already familiar with how to take it. They may have done it before. And then it's important to have someone follow up. Again, this would be a role of a case manager, or maybe a nurse or one of your MAs, to follow up and make sure the patient's doing okay the next day, especially if they're not that familiar with taking buprenorphine. And then you're going to have that patient return to the office or have a telemed visit in a few days or in a week or less to reevaluate how they're doing. And there's lots of really great protocols that already exist online. You don't need to make these up again or reinvent the wheel. So there's these that were made by It Matters in Colorado and through ACM. So there's this one that's on the clinic side that has all the checklists of what you need to remember to do in the clinic, or what your MA needs to remember to talk with the patient about when they talk to them on the phone. How are you doing? What dose are you taking? And then there's checklists to talk about with the patient patient and for the patient to remember. And instead of asking the patient to try to calculate a COWS score at home and when to, ask them to make sure you have 3 of these symptoms, that you're restless, that you're yawning, that you feel nauseous, these kinds of things. It really simplifies things for the patient. So, this particular guide is quite a bit longer. I think it's like a 4 or 5 page guide for the patient. The other option for the patient, I usually give them both of these options, is just the super simple 1-page one. So this is on the state website. This one's meant to be given from the emergency room. It's so really simple, 1-day guide, 1-page guide, and kind of has more just, pictures and that sort of thing of talking about how to start taking your buprenorphine at home. So you can go online, print out these resources, share them with patients, and it explains to them how to start taking their buprenorphine at home. Another way to address transportation barriers and to increase access to treatment is through mobile services. So this is something that we are hoping to start at our clinic hopefully next month. So like in our clinic, the way we're going to utilize this hopefully is to take our medical van to a couple towns that are kind of rural, that are in between our service areas, where we have clusters of patients that are already our patients who are on monthly injectable buprenorphine, to just go and visit those neighborhoods to administer those monthly injections for people who have had a really hard time, getting in for their monthly injections. And we talk to patients and they're really excited about that idea. It can be a real struggle to get patients into the appointments. So it seems like it might be a little simpler to try, bringing the shots to the patients. So we're going to give that a try and see how that goes. So, and there's a number of lots of different ways that this has been done nationwide with these mobile medical services. Let's talk a little bit about polysubstance use. So polysubstance, using other substances along with opioids is really common. I would say it's normal. It's to be expected, especially when patients are entering treatment. Almost all of my patients, when they're entering treatment, are using at least one other substance. For sure, most of my patients are using THC, but the most common substance I'm seeing, other than that, in my patients would be methamphetamine. And nationwide, there has been a large increase in the usage of the comorbid use of methamphetamine with heroin. So over the last 5 years, nationwide, going from like about 10% to 40-something%. In our practice over the last 5 years, it's gone from 23% to 47% of patients in our MAT program who are also using methamphetamine. And unfortunately, specifically in the Alaska Native population, has really suffered from the highest overdose mortality rates related to methamphetamines, which is, quite sad. And overdoses related to methamphetamines have been rising quite dramatically in the last 5 years. And when you about half of those overdoses are overdoses that involve opioids as well. And actually injecting methamphetamine with heroin actually triples the likelihood of overdose. And it's kind of sad because, sometimes there's this misunderstanding with patients that when you combine the two, that they kind of cancel each other out, the side effects, but they actually are much more dangerous. So what's important to remember is that, of the two things, the amphetamine and the buprenorphine and the heroin or the fentanyl, it's the opioid that's going to be the most deadly of those two. So if you can block the opioid, the fentanyl, you're going to greatly reduce the mortality risk by blocking that. So getting a patient with OUD onto a form of MAT is going to greatly reduce their mortality. So when you have a patient coming to you with comorbid opioid use and methamphetamine or stimulant use disorder, it's really important to try to stabilize that opioid use disorder with an MAT. to reduce their overdose death risk. Now, when we're talking about then trying to treat the stimulant use disorder, the most effective way to treat stimulant use disorder is with contingency management. Contingency management is rewarding patients for meeting their goals. It's providing an immediate reward for meeting their goals. So when a patient, their goal might be to be abstinent from methamphetamines. So every time they come in and give a urine sample that's negative for amphetamines, they get a gift card. Or it might be, their goal might be to come to their counseling appointment. So every time they come for their appointment, they get a gift card. And generally they're looking, the evidence is looking at amounts of like $100 a month. And it's trying to, contingency management is trying to, substance use is rewarding for the brain. And so contingency management is trying to help, helping kind of retrain the brain that these behaviors that are healthy for you and good for you, that now, life and your good behaviors are going to be rewarding, to get reward out of life and out of doing meeting your goals. And it's actually very, very effective. So for example, there's lots of examples, but this is just one in looking at cocaine use. This is one called escalating vouchers, where every time a patient comes in, they give a urine drug screen. Every time it's negative for cocaine, they get like a gift card. So the first time it's for $10, the next time it's for $15, the next time it's for $20. But if they were to come and give one positive for cocaine, it would drop back down to $10 again. So patients who did that program of contingency management had almost 70% sustained abstinence, versus patients who only did counseling without that had only 11% abstinence. So dramatically effective for reducing stimulant use. Another example is looking at just retention and treatment, and they had double the length of retention and treatment. And the cost of this program, occurring over 12 weeks, it was about $500. So really very cost effective for the outcomes when you compare it to the cost of medical care, the cost of medications, or the cost of behavioral health care. Very cost effective for those kind of outcomes. Another way contingency management can be used is in medications for opioid use disorder, would be in encouraging patients to come and take their get their medication injections. So this was an assertive outreach in youth for having patients come in and get their monthly naltrexone injections, and they got a gift card. And patients that were enrolled in that program were 3 times more likely, 75% versus 25%, got all their injections when they were in the program. So dramatically more likely to get their injections. So contingency management is hugely effective. It's very cost effective. And I definitely encourage you to utilize that form of psychosocial support to improve patient outcomes. There are no medications, FDA medications approved to treat stimulant use disorders. Some things that help a little bit: mirtazapine, even with not very good medication compliance, seems to reduce methamphetamine use by about 15%. And the combination of bupropion and naltrexone probably also reduces use by about 15%. So kind of a mild to moderate kind of reduction in use. It helps a little bit, not great, not FDA approved. And what's most important to remember, again, in patients who are using other substances, is that buprenorphine or methadone should not be withheld from patients who are using other substances, whether that's stimulants or sedatives. It doesn't matter. You should not withhold buprenorphine or methadone from patients who are using other substances. Again, that's updated in the ASAM 2020 guidelines. And in general, patients, historically, we know that patients who use cocaine tend to do really well in MAT programs. They had really good retention and treatment and really good success in stopping opioid use. But some studies have shown that patients who use methamphetamines didn't seem to retain in treatment. They tend to drop out of treatment sooner. But when they did stay in treatment, they did sometimes stop using methamphetamine, which was good. In our clinic, we looked at our numbers. We submitted an abstract that got accepted for presentation both this year, both at the ACM conference and at the Amerista conference coming up in November. We looked at our patient outcomes on patients who had opioid use and methamphetamine use. retention and treatment weeks of buprenorphine before we started low threshold cure for 2 years and after 2 years after we started. And we saw pretty dramatic increases in retention and treatment on length of buprenorphine therapy. So 9 weeks before we started increased up to almost 23 weeks afterwards. And specifically patients that utilized extended release buprenorphine were up to almost 32 weeks of buprenorphine therapy versus 13 weeks for those on sublingual buprenorphine. And I think that the main thing with that is really it reduces a lot of the transportation barriers. Patients aren't having to find a way to get to their appointments and get to the pharmacy, like every week, for these really frequent appointments and avoiding these lapses in therapy, which really simplifies things for patients. And patients who utilized the peer support in our program also stayed in treatment longer. Talk briefly about diversion. It's important to remember that buprenorphine does have a street value, but generally it's not being used as a drug of abuse. Almost always, buprenorphine is being used for its medically intended purposes to prevent withdrawal and craving. It's less than 5% of the time is it being used as a drug to get intoxicated. So, and generally what we know is that when people use buprenorphine without a prescription, they tend to, if they find that it's helpful for cravings or withdrawal, it tends to set them up for success that then they will tend to seek out treatment because they realize that it is a helpful medication for them. It kind of gives them a glimpse of hope. And most of my patients, when they come to me for treatment, have already tried buprenorphine, non-prescribed buprenorphine by the time they get to see me. And sometimes we hear of people injecting buprenorphine, even Suboxone strips. And it's important to remember that although patients may not get high when they inject those things because there's not really pharmacological differences with injecting those medications, that up to 1 in 4 patients that inject drugs actually develop an addiction to the ritual of injection and will kind of inject almost anything because of the addiction to that ritual, and that you may need to address that addiction to the ritual. And again, really also make sure that patients are safe, make sure that, make sure patients don't feel like they have to be ashamed about the fact if they are still injecting whatever it is that they're injecting, and that they have safe injection supplies. Talk with them about, if they're getting skin infections and, things like that. And monitoring for diversions. I talk to my patients that, the most important thing when I do your urine drug screen, it's not so much about other drugs that you're taking. I just want to make sure you're taking your buprenorphine. That's the most important thing. So when I do their urine drug screen, I send it off occasionally to confirm that there are buprenorphine metabolites in the urine, which is norbuprenorphine. The absence of norbuprenorphine in the urine is a sign of tampering with the urine. And occasionally we'll also do oral swabs if we're a little concerned that it's not the person's urine. So when we talk with patients, say that's the most important thing, is just that we want to make sure that you are taking your buprenorphine. When patients just struggle with taking their buprenorphine or struggle, and we're really, really concerned with diversion, our 2 main things that are go-to for that, along with, medication counts and more closely monitoring things, is directly observed therapy. So we do subscribe to a service that allows us to have a patient take their medication over their phone, and it sends it securely directly to us so we can watch the patient take their medication. If they really want to continue on sublingual dosing, it allows them to do that versus just changing them over to extended release buprenorphine, which most of our patients who end up doing that are actually very, very happy with that changeover. So we do have a lot of patients that switch to extended release buprenorphine. Let's talk a little bit about extended release buprenorphine. So of course, we don't have to worry about diversion with extended release buprenorphine. That can be a good thing for areas where diversion is a concern or where monitoring is difficult. If you have a patient who lives in an area where there's just no way to monitor them, they live remotely, there's no way to do a urine drug screen, there's no way to do medication count, and you're just really worried about that, that can be a good thing. It reduces that risk of withdrawal and relapse related to prescription interruption. So if you have that patient that constantly is missing their appointments over and over again, and they go through that cycle of running out of medication, going through withdrawal, return to use, and over and over and over again, they benefit from the medication, it helps, but then they run out and they go back to use. That's a dangerous cycle, because every time they return to use, that risk of overdose is there, and we worry about that. And so that the extended release injection can stop that cycle. And because you have a really long-lasting blockade, it's a high-dose blockade. It's the highest dose of buprenorphine available, so it's a very good blockade of fentanyl, and it's very long-lasting. So it's good for patients who are going to lose access to their medication for an extended period of time, like patients who are going out fishing or patients who are going to become incarcerated. They're going to have a long-lasting blockade that's going to last for months, and a long-lasting protection from overdose. So again, patients who are high risk of overdose, who have limited transportation and they can't get to their appointments, patients who are high diversion risk, patients who just like the flexible dosing, there's like, hey, this is a pain, I don't want to come into my appointments all the time. It's just more convenient. We have patients that switch just for those reasons, or people who just don't like the taste of putting it under their tongue. We offer it to anyone who wants it, but it is expensive. It's 2 to 3 times more expensive than the daily dosing. So we offer it to everyone, but these are kind of the folks who would benefit the most from monthly injectable buprenorphine. Primary medical care, every patient, every time they come in, we talk with them about how is your mood, how is your sleep, and how is your pain. And we try to treat everyone that has hepatitis C in our program. So asking about sleep, of course, all of our non-medical medication and non-pharmacological supports for sleep. But my biggest message is don't prescribe narcotic medications for sleep. Try not to. Try to use non-narcotic medications, even if they're off-label, like TCAs, mirtazapine, trazodone, doxepin, etc. Please don't try not to prescribe benzos or Z drugs to these patients. Really try to avoid that. But I always ask about sleep. I always ask about mood, anxiety, depression, and stressors, pretty much every time to every patient. Again, no benzos, please, no benzos. Buspirone, SSRIs, NRIs, mirtazapine, those kinds of things for panic attacks. Trying to help with some of the physiological symptoms with maybe some off-label medications like clonidine, hydroxyzine, and propranolol. And the VA has excellent resources on the treatment of pain. I would encourage you, that's where these are from the VA handouts. So I would encourage you to look up those, both medication and non-pharmacological treatments for chronic pain. And hepatitis C treatments, you can treat people who are actively still injecting drugs with hepatitis C. They have very low reinfection rates. Do not be afraid to treat people who are injecting drugs with hepatitis C. Make sure they have access to clean injection supplies if you're going to be doing that. Again, it's like, it would be like if someone, got gonorrhea and you were like, well, you had unprotected sex, so I'm not going to treat your gonorrhea because you're just going to get it again. They're just going to pass it to 10 other people. You got to treat them. Lots of data now that the reinfection rates are very low. Don't be afraid to treat people who are actively using IV drugs for their hepatitis C. Please treat them. And we don't have a lot of HIV in Alaska, but if someone is high risk, PrEP is something to consider for prevention for HIV. Sorry, I don't have a lot of time for questions here, but I think we have a few minutes available. Definitely reach out to me, though, personally, if you have questions about harm reduction and low threshold care.
All right. Thank you, Dr. Spencer. We do have some time for questions, and I've been trying to track the chat there so we can go through some of these. Do you have any suggestions for people who do not have coverage through Medicaid or insurance?
Yes. So that's pretty difficult, so that would be someone who is working where they're making just too much money to qualify for Medicaid, kind of in that in between, that's that really kind of difficult donut hole kind of area. I would say, for those folks, I think that as far as forms of medication, well, first of all, I would definitely have them look at the healthcare.gov, because there is a good chance that they would qualify for affordable insurance. If they're in that donut hole, that they could qualify for affordable insurance through the marketplace, and they may not know. Some people don't know that, if they really truly don't qualify for any insurance, and there's just no way that they're going to get any insurance. We do sometimes use plain generic buprenorphine. This is one of the only cases that we use plain generic buprenorphine because of the high diversion risk occasionally in this group of patients, because it is still the lowest cost medication. That doesn't really address the issue of the cost of the medical appointments. There's so many different costs associated with not having insurance. I would work really, really, really hard to try to get that person insurance, because that's going to be an ongoing because this isn't just a one-time thing. This is going to be for years and years. So, the cost of the medication is only one part of that. And of course, if the person chooses to be on naltrexone, we get lots of samples of that. We always have a fridge full of samples of that. So you could probably finagle getting maybe sample medications for them for that. But yeah, I think it would definitely be, really worth it to try to get them insurance. Our clinic doesn't really have a sliding scale, but I know that a lot of the federally qualified health centers do have sliding scales. So maybe trying to get them connected with that, and, doing maybe be able to prescribe them, generic buprenorphine in that case with increased, monitoring, which you could do over their video cell phone for random medication counts, in that kind of case. Those are kind of things you could do to reduce costs. You can reduce the number of visits too. Really depending on what your clinic was willing or able to do, reducing the number of visits by, having your case manager just check in with them, just to say, getting information from them over the phone about how they're doing, and doing medication counts and things to just reduce the need for as frequent of visits, while still keeping the patient safe, to cut down on costs. I think those are a few ways that you could cut down on costs for patients who are uninsured. That's a difficult situation. So we see it a lot less, thank goodness, due to Medicaid expansion. I remember doing MAT in the day before Medicaid expansion, and it was so horrible. It was awful. So thank goodness we have Medicaid expansion. I hope that it never goes away, because that was a nightmare.
Yes. Good points too about going to the local community health center for all kinds of other health needs that folks may have. So another question is, what about burnout?
Yeah, burnout. We were just having this conversation in our clinic yesterday with our team and our case management team about this, this whole thing of this after hours cell phone. And if it's like one person stuck with it, and they get all these calls from, patients, the importance of like taking turns of being the person that has to deal with, returning patient phone calls, instead of having that always stuck on one one person, because I think, yeah, if it's always one person's job in the clinic to always be that person that has to always deal with those crises and always carry that burden, then I think, yeah, that person's really set up to have to deal with burnout. And yeah, and I think having, if there's any way to have a backup provider to help out once in a while, that's really good. I used, years ago, well, until really just a couple of years ago, probably for the first 8 years or so of my career, I never had a backup provider. I worked, rurally, and I always had to be available by cell phone, even when I was on vacation. So now, in the last maybe 3 years, I have had backup providers. And so being able to go away vacation and know that people were taken care of and I didn't have to have my cell phone on. And so I think training people to be able to answer questions for you while you're away and taking that time for yourself, I think is really important. And I think also, I think it's easy to get burnt out as, I think especially early, I've seen recently too, I think early when you're starting to work in this field too, it can be frustrating. And I think it's easy to take it too personally when you see people struggle and you see people not do well or fall out of care, to take that personally as like a personal failure when it's really not. And that can be really hard. So I think having like a group of other people, that maybe, a network of other people that also work in this field of substance use can be helpful to share those experiences that we've all been there with patients that, we felt really personally invested in. And when they didn't do well and struggled or fell out of care or something really bad happened to them, we really kind of took it personally. It was really hard for us, when it wasn't our faults, but we can't help but feel that way sometimes. Yeah.
For sure. Very good. What about off-site or on-site pharmacy-only visits for Matt? You kind of did mention that, but this was one of the questions. They were suggesting, what about people going to Walmart or, an outside pharmacy kind of a thing?
Yeah. So I think that would be like if you wanted patients to pharmacy only visits. So like that would maybe be like if you had a patient that you were worried about and you didn't want them to pharmacy only visits. So maybe like if you only wanted them to get like 1 day supply at a time, or like you wanted them to just go like for daily dosing, maybe that's what that question is about when they say pharmacy only visits.
I think that you actually fought, after they asked the question, you mentioned, what about at your clinic that you allow others to support people who are coming in maybe off schedule so that they can, they missed an appointment, they're coming in at the wrong time, but you have a setup with your team so that someone can fill in and do that.
Yeah.
Even though it's at your clinic, it's not a separate pharmacy. They were curious what you thought about that idea.
Yeah. So if I was out of the office or the patient came in on a day that I was off, some of the options might be like they might do a urine drug screen. Maybe if that was something that I felt like they needed to do or the case manager needed to do, they might just have a quick check-in with the case manager, just say, hey, how are you doing? Who might make a few notes in their chart. Maybe they would bring their medications in account if that's something we would want them to do, to kind of substitute, for a visit. If they needed to have an injection, we have trained, our nurses to do medication injections. So that's something that if I wasn't there in the office, but a patient needed to have an injection, the case manager could check in with them, just, hi, how are you doing? Do you have any needs? So that they could communicate those with me. if need be. But the nurse would be able to do their medication injection if they were due for that, so that they wouldn't miss it. We don't want, we hate to have, if a patient is like, okay, this is the only time I can come in and it has to be right now for my medication, we just don't want to miss that opportunity. So if I'm not right there, we have a couple backup people that we have trained to do those injections so that it doesn't have to be me doing those injections. And also to, when patients are traveling, that we do telemedicine and they can do their urine. If we want them to do a urine drug screen, that they can do those at any, we'll send the order to a remote hospital. We also have, we'll send patients sometimes when they're traveling or home. If we want them to do a drug screen, we'll send them with oral fluid swabs. So, because those they can collect over the video and then they put in an envelope and then they can drop in the mail. So that's another way to do remote testing and do a video visit over the phone so that they don't need to come in at all, but we still are able to kind of check in with them. And
the question also came up, and any difference in the way you might look at this with regard to the monthly injection? In terms of using a pharmacy outside of your clinic.
Yeah, well, they can't give the monthly injections at the pharmacy, if that was the question. Okay. I'm not sure.
I think that was part of the question.
Yeah. They can't give injections at the pharmacy, if that's the question.
Right. They were actually wondering what your opinion on that was. I think maybe they understood that was not possible.
Yeah. I'm not completely sure as far as, they're obviously, there's certain things they can do at a pharmacy, like they can give flu shots at a pharmacy. There are certain kinds of injections that they can give at a pharmacy. There are certain injections that at a pharmacy, like if someone was due for their naltrexone injection, because they carry naltrexone at private pharmacies. And if it was a follow-up injection and they weren't late for it, that's a super low risk injection. I don't see any reason why that couldn't be given at a local pharmacy. That should be fine. I've never heard of it happening before, but I don't see why it couldn't happen. In theory, now extended release buprenorphine, that's a whole nother problem because that's not carried at local pharmacies. That comes only from specialty pharmacies and it's mailed directly to the clinic. So that's not an option. There's just no way that's an option. That is only mailed to the prescriber's clinic. So they have to come into the clinic for that injection. That's the only place that they can get that.
Okay, great. Thanks. Yeah. Another question. How do you get around the $75 SAMHSA cap for contingency management?
You just got to take the money from someplace else. You can't take it from the SAMHSA grant. You got to take it from someplace else in your funding. So you got to take it from other clinic money. So if you want, if anyone's interested in contingency management information, I just finished an opioid response network contingency management training, and they gave us a nice contingency management toolkit along with some quotes related to interpreting the Attorney General's, information on interpreting the laws. And there's a big thing right now with the state of California that's going against the federal government on this. So we'll see how that turns out because the state of California wants to do a really big program for contingency management. So we'll see how that comes out. But so yes, you cannot use the SAMHSA grant money more than $75 a year, but that does not mean that it's illegal to provide contingency management more than $75 a year. If you are using it, if you have an evidence-based program, especially treating stimulant use disorder, and there's certain things around it. So you got to take the money from someplace else, just like your general clinic funds, and there's certain things it has to be very well documented. You can't advertise it. And it needs to be, you need to treat all patients that are in the program exactly the same. There's certain criteria that you need to do to make sure you're doing it correctly. It's pretty basic. Then you're within the law and it's okay, because evidence-based contingency management is not $75 a year. That's not going to do. it's a nice idea, but it's probably worthless. So, you're looking at more like $100 to $200 a month. The studies that are looking over, most of them are like 12-week studies. So it's, I think we're going to see pretty dramatic changes in that over the next couple of years, given the huge rise in stimulant use disorders and the rise in evidence, and everyone's talking about this right now, that it's the outcomes are so dramatically effective. It's such a good investment of money that why wouldn't you utilize it as a treatment?
Mm-hmm.
So you just need to make it clear that the money is not coming from the SAMHSA grant, that it's coming from a different pool of money. You need to make it clear where that money is coming from, and you need to follow some specific guidelines. So I can share. Oh, Janet shared one of the brochures, and then I'll try to share. Let's see.
Okay.
Yeah, that's a brochure. Yeah.
Yeah, in the chat, there are a number of great resources that have been shared as you were speaking. Project Hope, getting the Narcan kits, the Division of Behavioral Health MAT Guide, which you were, I guess I could say, author of, and the ASAM guidelines. I Know Mine with risk reduction kits, and information about vans to deliver services. Another question that's come up in the chat is, how can medical and behavioral health programs deal with CFR 42 barriers in the sharing of documentation? And this is from Michael Horton, and it says, our attorney just reiterated that this is a real barrier and cannot be ignored.
Yes. So I think that that having if you have an integrated program, that having very specific, listen to your attorney. Obviously, I'm not an attorney, but having, it's important to have very specific, if you're, probably you all are, but if you're a program that falls under that, to have very specific releases that are specific to your integrated care program, that specifically release that sharing of information between the two programs. You can make a release like that. Like, it's possible. You can do it. They exist. So make one, and then have your patients sign it if they agree, so that you can integrate your program. The CARD 42.2 is there for a reason, but if the patients agree, like, how many people have actually been sued because of CARD 42.2? Like, almost no one ever, especially by a patient that gave you permission to talk with their counselor. Like, when you talk about realistic evaluation of risk, like, do what's right for your patient. Like, make the release that's in doing your due diligence for what is right for the patient, and have them sign it. And the patient is agreeing for you guys to talk to each other. It's within the system. I think don't be that scared of that. It's realistically, if you look at all the legal things, like, almost no one has ever gotten sued about that. So don't worry so much about that legal stuff. Do what's right for the patient. That's what I would say. But I'm not a lawyer, so maybe don't listen to me for legal advice.
Great points, though. Great points. Let's see. Another interesting question. Any concern about your mobile clinic being robbed, and what safety measures are in place?
Yeah, no, we wouldn't carry. So we don't carry at our clinic sublingual buprenorphine. We never have. We only have Sublocade, and I don't think people are so I don't think people are interested in stealing Sublocade, but we do keep it locked. Sublocade, monthly injectable buprenorphine. Sorry, trying not to use brand names, but it's pretty. It's not. I don't think it's got a really high. Not a lot of people trying to steal that. It's not like a high diversion kind of thing. So yeah, we never carry sublingual meds. We only have the patient, we prescribe that for the patient to pick it up themselves at the pharmacy. So there would really be no reason for them to steal anything from our clinic. Yeah. Down the road, we've been talking about it would be pretty neat for us to have a mobile OTP, because the Kenai Peninsula really needs an OTP. And that's quite a few just down there. That's a whole different security thing there. Yeah. That would be some multiple levels of security needed. But for this, yeah, extended release buprenorphine, the security level needed is not that high. We do have the cooler and fridge, it does have locks on it. But it's not the kind of thing that people are looking to steal. So it's pretty easy.
Good. Another question, does the monthly injectable buprenorphine help with pain management?
I don't know. It's a good question. There's no studies on it yet. So the thing like this, I wonder about this, and I have patients ask me sometimes. So first of all, it's the highest dose of buprenorphine available, as far as what insurance will pay for, so when we think about buprenorphine for pain, what we do know about buprenorphine for pain is that like when we do sublingual buprenorphine is that the analgesic effect of buprenorphine, it only lasts for about 4 to 6 hours. So you need to dose it like 3 times a day, or like in the hospital, we'll dose it 4 times a day. Like 32 milligrams 4 times a day when people are having acute pain in the hospital. And there's no ceiling effect necessarily on the analgesic effect of buprenorphine. There's studies that show that maybe you can even keep going up on the dose and get more ceiling effect for the analgesic effect. But there is a ceiling effect probably for the effect as far as craving control. That's why insurances won't pay for more than 24 milligrams a day for treatment of addiction. It's a separate thing. But I do wonder, so the dose, when you have extended release buprenorphine, and if you have someone on the standard dosing of 300, and then 100 as your maintenance dose, you stabilize at serum drug levels that are a little bit higher than if you had someone on 24 milligrams a day of buprenorphine sublingually, but they're steady. They're the same all the time. You don't have the little ups and downs. And so I don't know, it hasn't been studied. Like, do people feel like just constant same pain relief as you would with the buprenorphine? You don't get those ups and downs. So you don't get that feeling of like, oh, I take a pill and I feel a little better. You don't get that little up and down feeling of like, I feel better when I take this thing, which maybe that's not a good thing. Maybe it is psychologically, people like it maybe because you feel better when you take it. So you lose that part, which could be good or bad, depending on the patient, that you don't have that thing to take multiple times a day. If you go to 300 and you stay at 300 milligrams, you get really, really super high serum drug levels. It would be really interesting for someone to study, but no one studied it. So I don't know the answer to it. What I've told patients is like, if I have patients who it's kind of optional, like they don't necessarily need to be on extended release buprenorphine, they're just kind of like considering it because it's more convenient for them or whatever. I'm like, well, we could just try it and see. If you hate it, we can go back. It does take a few months to stabilize, for the levels to stabilize. The first month, the levels go down at the end of the month. So they might need some supplemental sublingual buprenorphine, especially at the end of the first month. They starts out at levels that are like higher than 24 milligrams a day, but at the end of the month, it drops down to levels that are more like 12 milligrams a day. So you have to supplement at the end of the first month. So that's important to remember. It would be, I think the biggest difference is that you have higher levels, but they're steady all the time versus the ups and downs. And so I think it's probably patient specific, and no one knows because no one studied it. But it doesn't hurt to try it. And patients could go back if they don't like it. Assuming they have Medicaid because it pays for it, it can be difficult. Most private insurances, we've been able to get them to cover extended release buprenorphine. We've had a little struggle with some, certain ones, a big struggle, but if a patient has Medicaid, that's easy. So I'm sure we'll see studies done on it eventually, but right now we don't know.
Okay. So would you want to comment about naltrexone for alcohol cravings? That was one of the questions.
Yeah.
Discuss that.
Naltrexone for alcohol use disorder. So in general, so are we talking about just in general for alcohol use disorder, or are we talking about for like patients with dual diagnosis, opioid use and alcohol use disorder?
They didn't mention it as a dual thing, just
Mhm.
as alcohol. So.
Yeah. So I think, I think for me, for most patients in general, it's probably my go-to for alcohol use disorder. In general, it's simple because it's a monthly injection. For most patients, some patients do daily dosing. It helps with cravings. It helps with reduce the enjoyment of alcohol. I think people sometimes have unrealistic expectations on how helpful it's going to be. If you look at the fine print in the manufacturing, for the 90% subset of, or 87% subset of patients, who were still drinking alcohol when they started their naltrexone, they only had a 20% reduction in heavy drinking days, versus the subset of patients who were abstinent from alcohol the week before they started the naltrexone that had the 90% reduction in heavy drinking days. So ideally, if you get a person to be abstinent before they start it, then they're probably going to have better outcomes. But also, if a patient cannot maintain abstinence before you start it, don't withhold it. It's still probably worth it as a form of harm reduction to start it. There are off-label ways to use naltrexone for binge drinking. So if a patient doesn't want to take it every day and they're just binge drinking, you can, there's off-label use of naltrexone where people will take it just before they plan to go out to drink to try to reduce their use of alcohol. And some people feel like they like that, or that it works better, like they're not used to the medication. They're not taking it every day. They're not used to the way it makes them feel. And they just take it before, like an hour, 2 hours before their planned drinking episode. And then they will reduce the amount of alcohol they drink in that planned drinking episode. So in general, the American Psychiatric Association recommends it for most patients. It's first line. Acamprosate can also help to. Acamprosate helps to encourage abstinence as well. It's more difficult to take because you have to take 2 pills 3 times a day. It's really difficult to take medication 3 times a day, but it definitely can help with cravings as well. Acamprosate can. And then if a patient experiences alcohol withdrawal when they stop drinking, and their alcohol withdrawal is relieved or improved with gabapentin, then they are likely to do well on gabapentin after, as a form of MAT afterwards. There's a study that came out that showed good outcomes on continuing patients on gabapentin to encourage abstinence afterwards. So that's another thing that I would encourage, for if we're talking about MAT for alcohol use disorder, that shows promise. There's tons of off-label stuff, for alcohol use disorder, but as far as evidence-based, disulfiram doesn't have any evidence. I use it in patients all the time, but there's actually no evidence that it works. We use it with directly observed video monitoring. We try to. We have I encourage, if any of you have COVID money left, there's apps for directly observed video monitoring COVID money will pay for that. They're great. We use one called eMocha. I'm sure there's other ones too. They're meant for like patients, originally designed for like TB treatment stuff, but they have them for substance use disorder. So they're great. Patients just open the app on their phone. They videotape themselves taking their med. And then it securely transmits it to you, medically. And so you can watch people take their medications, and they will save them up. If they don't have cell phone service, it will save it up until they connect to Wi-Fi and transmit the data to you. So it's a really nice way to see if patients are taking their medications, so we have patients who are like, they swear they're taking the buprenorphine, but they're not showing us any evidence of it because they're like showing up for their appointment every 2 or 3 weeks instead of every week, and So if anyone has COVID money left, I encourage you to buy a subscription to one of those apps for your patients because we use it all the time.
Yeah,
all
that
different
sounds
kinds of
like
stuff.
that would be a real,
Yeah. So you can use it for
Efficient.
that kind of thing, for disulfiram. You can use it for buprenorphine, anything where you want to have, we use it for our oral drug screening, show us, videotape yourself doing the oral drug screen, videotape yourself counting your medication. I mean, we use it for lots of different stuff. If we can't necessarily, even if the patient doesn't have cell phone service right then, they can still videotape themselves doing it. And then they can connect to Wi-Fi later, like at the library or whatever, and download it. So it's nice that even when a patient doesn't have cell phone service, it still works. So
it's cool. It's a great tool. Sounds like.
that's a nice tool for like telemedicine or remote medicine
And
for monitoring
link to that
medication
is
compliance.
in the chat also, just so.
Yeah, and I don't mean to to promote any particular brand. I'm sure there are many other brands that do the same thing. It just happens to be the one I know about that we use in our clinic.
So we just have a few more minutes, but there's one more question. And it's someone wanting you to maybe talk a little bit about the dangers associated with quitting heroin without using any kind of medication.
Yeah.
And I like to ask too, if you might add a word or two about particularly that sort of thing with women who are pregnant.
Yeah, that's a really good question. Because I think it's something that we forget to talk about sometimes now, because we're at a medication for addiction treatment conference.
Yes.
And I think we just think everyone knows these kind of things, right? Like, isn't this just something that people know about these medications and how they work, and that these medications are important for people to take? But that's not necessarily true. People don't necessarily know what these medications are, or why people take them, or how. So when we talk about like people stopping using heroin or other opioids, let's say oxycodone or whatever it is, cold turkey. So when we say, is it dangerous for them to quit? So there's two things for that: long term and short term. So is the actual withdrawal dangerous? Will you die from withdrawal? That's one question people have, like you can from alcohol. That's, people hear people going to DTs and you can die. Will that happen from opioids? No, probably not. Probably you'll wish you were dying because you're going to feel horrible, but you'll probably be okay. In about 5 to 7 days, you'll come through it on the other end. What happens, the problem with opioid use disorder is that, yes, you can go through withdrawal, or we used to call it detox. Now we call it withdrawal. Withdrawal management is when people go into what we used to call detox, or go into a withdrawal management bed in a hospital, in a clinic, in a residential treatment. We give them medications to help them feel better, to sweat it out and get through it. And then a week later, they feel okay. But unfortunately, what happens is the craving for the drug is still there, and it doesn't go away. And it doesn't go away for months and months and months and even years. That craving is still there, and it keeps coming back. And so what happens is, if a patient doesn't go on one of these medications for the treatment of opioid use disorder, or MOUD, you'll see the abbreviation, more than 90% of patients will go back to using. And that's a really dangerous time. That period of time after you've gone through withdrawal and you've been abstinent and you go back to using, the risk of overdose is between 10 to 30 times higher in that period. It's very, very dangerous time for people, because your body is, you lose your tolerance in about 2 weeks after you stop, and you go back to using, your body isn't used to it anymore. And it's really, really easy to overdose. So what we know is abstinence-based therapy, or trying to not use, right? Using your willpower and trying to not use opioids does not work. Yes, occasionally, like you might be that 5% of people that is just lucky and is able to do it. But for 95% of people, that doesn't work. And it's, it's a very treatable medical disease. There are medications that work very, very well to help treat it. So depending on what medication is the best medication for that person, they may or may not need to experience that 1 week of withdrawal symptoms. So Kathleen just posted that there is a device called the Bridge device, and there are certain medications that can help people get through that 1 week of withdrawal symptoms, if they decide they want to start on the medication naltrexone, they do need to go through withdrawal for a week before they can start on that medication. If they decide that they're going to start on buprenorphine, they do not need to go through withdrawal before they start on that medication. That's part of why that medication is much more popular, because it's pretty hard. The withdrawal, even patients who are highly motivated and go to an inpatient withdrawal management setting, 1/3 of patients are so uncomfortable that they will leave before completing withdrawal because it's so uncomfortable. It's just really difficult. So most patients will choose for their for their MAT, their medications for addiction treatment, or their medication for opioid use disorder treatment, will choose buprenorphine. Or if you live in a city like Fairbanks or Anchorage or Palmer, you could choose methadone as your medication, but you have to go into the clinic every day for that. So like my patients who live in Homer and Ninilchik, they can't be on that medication because they can't go to the clinic every day. So they have to choose between methadone, they have to choose between naltrexone and buprenorphine. So those medications, especially within that first year, they increase the success rate by like tenfold. That a patient's going to be able to remain abstinent from opioids. So they are hugely successful, and they reduce death rates by about 80%. So they are life-saving medications. They are the gold standard in the treatment of opioid use disorder. So is it dangerous for people to go kind of cold turkey? It is, yeah, it's dangerous because the mortality rate is high. And it's very risky to not take these medications. It's always a patient's choice. We can't force anyone to get medical treatment for any disease, but it's dangerous not to have medical treatment for opioid use disorder. And so we always encourage people to take medication because it's going to greatly reduce their risk of death, and it's going to greatly reduce their risk of returning to using opioids.
And that would all be true for pregnant women as well.
Yes, for pregnant women, there was a study that came out on pregnant women. It was a little while ago now. I want to say it's 4 or 5 years ago, where they actually, it was in incarcerated women, which was maybe a little unethical, that they had incarcerated women go through withdrawal, and they looked to watch to see like, did anything bad happen to the babies? And then, so none of the babies died, which was good. But like up to in certain subsets of the women, up to 3/4 of them returned to using heroin again, which was horrible. I mean, that's kind of the whole point. Like, you can't be a good mom if, you know, so at first it was touted as like, hey, look, it's fine to allow to get pregnant moms completely off opioid. The concern is when you treat pregnant women with opioid agonist therapy like buprenorphine or methadone, when babies are born, they do experience a period of, it's roughly 5 to 7 days of neonatal abstinence syndrome, where they're kind of fussy and they have a little bit of a hard time. Sometimes they need medical treatment for that. About half the time, or a third of the time, of buprenorphine, they need some medical treatment for that. But it's a very treatable temporary condition that doesn't cause any long-term problems for the baby. And so the thought was, oh, hey, if we could just get mom off of these opioid agonist medications, then we wouldn't have to worry about this in the baby. But what happened was, yes, we could withdraw the mom, and the pregnancy would probably be okay, and the baby wouldn't die. They were worried about miscarriage, is what they were worried about. So most of the time that was okay. There wasn't a miscarriage. The babies didn't die, but then the moms went back to using heroin, which is horrible. You can't be a good mother when you're using heroin. So it is, so the American College of Obstetrics and all of the societies of medicine are all 100% on board with the fact that the standard of care in pregnant women is to be on buprenorphine or methadone throughout the pregnancy in opioid use disorder. Occasionally a woman who's already on naltrexone will remain on that, although it's not studied in pregnancy, with informed consent that we don't know the effects really. And then to continue during pregnancy and throughout, and then afterwards in breastfeeding as well. It is a standard care in pregnancy. Babies are healthier, moms are healthier, and everyone's healthier in the long term if moms stay in treatment. So yes, pregnant women should definitely stay on their medications. And we have lots of pregnant women that come through we just had two pregnant women that had babies born in the last month or so. This is pretty exciting.
Great. Well, we're a little bit over on our time here, but thank you for fielding so many questions and for your great, very informative session with us, Dr. Spencer. Welcome back to our Recovery Roundtable, and we will be discussing awareness and solutions to MAT's stigma. Our facilitator is Austin McNeil Brown, and the panelists are Rachel Gearhart, Jennifer Galvin, Christina Love, and Brooke Feldman. Austin is an affiliated researcher at the Lerner Center for Public Health Promotion and a PhD student at the Maxwell School for Citizenship and Public Affairs at Syracuse University. Austin has dedicated several years to the study of emancipatory processes involved in recovery from substance use disorders. Austin believes that recovery processes require recovery-specific theory, phenomenological methodologies, and strength-based metrics derived from successful recovery experiences of survivors. Joining him today are a group of panelists who are fierce advocates for people experiencing substance use disorders, mental health disorders, and survivors of trauma. These strong and diverse individuals make significant impacts on their community and state workforces by offering trainings, webinars, and leadership to improve the quality of care for traditionally stigmatized individuals. Please welcome Austin Brown and our panelists, who will each introduce themselves: Rachel Gearhart, Christina Love, Brooke Feldman, and Jennifer Galvin. Welcome.
Thank you. It's quite a conference you guys had. I'm Austin Brown. I think maybe we should start and kind of go around and introduce ourselves. And I think one of the things that we will focus on will be the relationship of stigma, particularly to the type of work that each one of us does. So in my case, for example, doing research on stigma is one of the areas that I've focused on. Why don't we start with Christina? Tell us a little bit about yourself.
Guyana, Godeshish. Thank you, Austin. I'm very, very, very grateful to be here and be joining all of you. My name is Christina Love. My pronouns are she and her. I'm originally from Ikagik Village, grew up in Chitna, and today I'm joining you from the beautiful Ocontacukwan of the Tlingit Nation, also known as Juneau, Alaska. I work for the Alaska Network on Domestic Violence and Sexual Assault. My position is on intersectionality with the primary focus on trauma and substance use. But one of the ways that we talk about that is that we talk about trauma and substance use and mental health being a really natural way that people survive. The unnatural thing is the harm that happened to them. I'm a person who has formerly used substances. I'm trying to use language that really fits my individual pathway. Sometimes we talk about that as being a person in long-term recovery. And I do recovery coaching, and I'm also a certified peer support specialist. I'm very, very grateful to be here amongst this incredible panel and all of you. Thank you.
Excellent. Thank you. Jennifer?
Maybe. There we go. I'm Jennifer Galvin. I am the primary trainer for peer support professionals at Alaska Behavioral Health, and I have been doing this job in peer support for 13 years, starting down in Washington State and moving up here 3 years ago. Something that I bring to the table when it comes to this is taking away the judgment and shame and really detaching the diagnosis and labels that come with why they picked up the first time, why they chose the behavior choices they did, and really putting it down to what happened to them. What happened to us to make us need these outside entities to make it feel okay? And let's start making the story about what they have overcome and less about what they have been told is wrong with them.
Excellent. Rachel?
Hi, nice to see you all. Great to see so many familiar names, even though I can't see all your faces. My name is Rachel Gearhart. I've also got my pronouns in there. And I am the Chief Operating Officer at GME Health and Wellness in Juneau, Alaska. I'm a licensed clinical social worker, and I also have my CDC-1. And so I'm not entirely sure why they invited me, but I'm honored to be here. And I think what I can help bring to the table is I see myself and many social workers as ultimate optimists and really trying to be creative about the ways that we can always try something new. I don't think we're ever at a point where we can't try something else.
Excellent. And Brooke?
Hello, good evening. I am coming in hot from Philadelphia, Pennsylvania. I sent a message to the organizers that we have tornado warnings right now, and I've lost power once. So if you see me abruptly disappear from your world, I'm sure it's just power. And if you hear that there was a person with lived experience of having had a substance use disorder and who was supposed to be on a panel, but then got swept away by a tornado, that was me. But if I get to stay, the perspective I bring is having lived with a substance use disorder as an adolescent and young adult, and having lost my mother to an overdose death when I was young, sort of just a personal experience. And then I'm also a social worker and have spent time in peer support services and do all kinds of things. Currently, I am the co-founder of the Pennsylvania Harm Reduction Network. So we're focused on like statewide harm reduction policy work. But lots of different perspectives, and I've worked in a variety of settings where MAT was offered, and have spent too many years, trying to dismantle the misinformation and stigma and honestly discrimination surrounding the use of medications to support wellness. So glad to be here, and hopefully I stay. Thank you.
Excellent. Thank you. So I think one of the things that is important when we talk about stigma is to kind of open up with a definition. And Brooke had mentioned the word discrimination and the relationship. And that's one of the things that I think is important, is the relationship between stigma and discrimination. As far as the dictionary goes, stigma is negative attitudes and behaviors aimed at individuals who are associated with a specific social group or status. And it is deeply discrediting, experienced as labels, stereotypes, status, and of course, discrimination. I think one of the things that is important to keep in mind is that we're talking about power, and we're talking about who has the power to stigmatize whom, and what that means both at the personal level, at the institutional level, and at the structural level. And of course, at the structural level, when we get into things like laws, we're talking about things like discrimination. And the relationship of stigma to different types of identity is also really important, because many of the people that we experience, that we come across in our professional lives, have experienced multiple types of stigma, and they're often layered on top of one another in intersectional ways, which provides us with a roadmap of exactly what the systems of power that are disenfranchising them. And of course, MAT stigma being a major one that we come across every day in our work. So let's start with, Christina, why don't you give us a short kind of take on bias and stigma and how it relates to opiate use disorder specifically?
Yeah, absolutely. I love that you started out with that. We often talk about shame, but we don't talk about where that comes from or how it relates to racism, prejudice, biases, and discrimination. And so, and that really can be categorized totally different from different parts of the world. But here in the United States, what that looks like is that prejudice is backed by the state. So that means somebody's own personal opinion that's based on myth is backed by laws, policies that are sanctioned. And so, when we think about the history of this country, this country, the United States, was founded on first, the enslavement and the genocide of the indigenous people, and then later people from Africa. And there were a lot of policies in place, and that's what we're talking about, like that institution. So the intersection between opioid use disorder is that we cannot separate people's identity. So when we're talking about all of the different ways that people are experiencing inequity within the healthcare system, it's important that we take in, this holistic view of what people are experiencing, and that one cannot be pulled from the other. And that's really what intersectionality is that if we're talking about opioid use disorder, then we're also talking about socioeconomic status, whether that's temporarily poor or experiencing poverty. And there's a difference between that as well as all of the other different ways that, that people show up. Specifically for MAT, I think that a big part of this goes back to that single story of what recovery looks like, and for a long time, and we see that in funding, there's a lot of funding that goes to the medical model, most specifically the abstinence model. And so, and this is, this has been a hard fought battle for the recovery movement too, is the full acceptance of people's pathways, that there are as many different pathways that people who are actively using drugs as there are for people who are recovering. And it looks totally different for every single person. And so a lot of emphasis around people that, right, the story is that they were experiencing a lot of difficulty. They started using substances and now they don't use drugs anymore and their life is totally, totally better. And we know that that's just one part of the story. Harm reduction is a really big part of that. But all of the different ways that that shows up, for an example, some policies around stigma could be our own personnel policies. So we might have an organization who's really accepting and who's done a lot of work to be more inclusive, but then at the same time, your organization might have policies that says that if you show up intoxicated, you'll be fired. And rather than having a conversation about what might be happening in your life that substances are starting to prioritize your well-being and your income that supports yourself or maybe your family.
Excellent. So maybe one of the best ways to start off is to just take a swing at what the most valuable strategies and tools for reducing stigma that we've found in our work. And I'll start with Brooke. And it doesn't have to be limited to that, but I think one of the things that helps us to connect the meaning of stigma is the way that we develop our practices around it and the way that we address it. So, Brooke, what would you say are the most valuable strategies or tools for reducing stigma?
Yeah, so there's the ones that we know from from research, right? And I know, Austin, you've been a contributor to that, which is great. So Austin may not say it, but I'll say it. Please look at Austin's work with other folks on this topic, because I've learned a ton from it. But I think the reality is that when it comes to stigma, we're often just carriers of this sort of information or misinformation that we picked up along the way somewhere, right? And so how we dismantle that is for people to have an opportunity to even just understand that why they think the way that they think isn't because this is original thought or their own personal sort of born opinion, that somewhere along the way it was probably passed along and transmitted to them, and then they transmit it to others. And for me personally, I use myself. I have the luxury, right? I am a person with lived experience. I am somebody who did not come out of the womb being yes, MAT for all. This is great. I I was indoctrinated in a lot of the messaging that the folks that we're thinking of right now were indoctrinated, right? And so someone who was institutionalized as an adolescent and young adult, it was in the very places that were supposed to be helping me where I learned things like what Christina said, that there's only one right way to recover. And that was really the abstinence space, like, immediate and total lifelong sustained abstinence is the only way. And then certain pathways were the options, but it wasn't the variety that is available. And it was also in the settings that I was institutionalized in that were supposed to help me that I learned the whole like MAT is replacing one drug with another, is taking the easy way out. Methadone rots your bones, all kinds of things, right? You've all heard it, and there's a whole we have a whole panel on the subject because you've heard it. And so, for me, I mistakenly transmitted that for some time, including to loved ones who were struggling. And I would say things like, if I was able to overcome an opioid use disorder without the use of medication, then you should be able to too, right? And I thought that I was being helpful to my loved one who was, utilizing methadone. We were in the same place, had two different paths to wellness, and the reality is we both have lives that are full of purpose, meaning, love, family. We wound up in the same place, right, with very different paths. And so I just kind of will use the fact that, hey, I didn't start off in this place of being super affirming and embracing of, the many varieties of ways that people find wellness for themselves with equity, right? I wasn't born this way. And I think by normalizing that for many folks and not having a posture of I can't believe you didn't know this. We tend to make people wrong for not knowing what they don't know. And so I think, not being a carrier of that practice and say, it's understandable. I remember a counselor telling me, hey, Brooke, if you don't go to meetings for the rest of your life, you're going to end up in jails, institutions, or death. There's no other way to recover. What are you talking about? Right. I learned that. And so I transmitted it. So it was a long answer, Austin, much longer probably than I was allotted time for, and I apologize. But I think really being able to approach folks with the humility of, I don't know that anybody on this Zoom, knew this stuff, right, since birth. And many of us work in the field or had the opportunity and the privilege to get higher education or whatever it might be. And that's how we came to know. And I think just normalizing that seems to help bring folks along versus eliciting a defensive response, right, where then they just kind of dig in even more. So I think with humility and compassion for why the stigma exists, which I don't think any of us today in this moment in time are interacting with anybody who was the original creators of it, right? We're talking about the carriers.
Yeah, and that's a really good point about compassion and compassion as a practice, as a professional practice, and using that, leveraging that as a foundational point to begin, right? So many of the people that we deal with have a lot of different types of social disparity that they are facing. So beyond stigma, what specific forms of social disparity exist for this population that we see, or that you see as individual practitioners in what you do? And how are these reproduced through the systems that you work in, the language, and the organizations? And why don't we start with Rachel?
Excuse me. Thanks, Austin. And thanks, Brooke, too. I kind of stepping back to the previous question, too, I think sometimes some of the tools are not tools at all. We need to use a lot of standardized assessments and screeners, and the ASAM is really useful. And sometimes it's you send off a application for treatment and, they don't meet that level of care. And sometimes it's not the tool. The tool can be the barrier. That individual conversation can really help us move past just, these numbers said this. And that, I think, translates also to, there's a lot of ways that we can reduce paranoia about data collection. Just because we have these standardized tools that are normed and validated, not saying they're perfect, they're not, but data is not the enemy. Data can be really helpful for us, and we have to connect people with what it means for them and how it will be used. And then agencies, and providers and individuals who are helping people, arming them with really helpful data that's really useful so that we can use it for good and not just stigmatize people through numbers. And it's a challenge. I don't have the perfect answer for that. But one of the ways I think we can start to do that at places like my experiences with is trying to be really clear with our health literacy, trying to use language in our orientation documents to services that are really clear, and kind of to borrow Brene Brown, clear is kind and kind is clear, trying to be simple, trying to be plain language, trying to truly not just say, do you have any questions, and quickly move on, leave space for questions to be asked, and take a sense of curiosity when someone's pausing and asking, anything else I can help you with? Or is there anything else? Or I saw something there. Can we talk about that more? And an example I thought of when we were talking about this question is when we ask people about their gender identity or gender expression or sexual expression, there's a lot of terms that data means something to a lot of us, but may not mean something to other people. And so just being really clear about what we are looking for and how we use that information is one way that I think that we can work on that social disparity kind of angle.
Jennifer, do you want to, since you're the peer trainer, I'm sure you have some insights into this.
So I actually love that we're talking about it from this visual perspective of what works and what doesn't for one person is completely different for someone else. And the story I use in the training is I am one of 3 girls who is raised in the same world of chaos, trauma, and abuse. And my late sister passed away in 2004, clean. I want to say that. She was clean when she passed away and left this world, but it doesn't mean she didn't have to fight for it. And then my older sister is still one of the people struggling with addiction in my family. And then there's me who, for whatever reason, was blessed to never pick up a drug. I have both lines of my family and I never picked it up. And so I take that as my visual to get rid of the judgment, get rid of the labels that say you are going to do this because that's what you're stuck at doing. Everyone has a choice in trying to love themselves. And everyone has that fight every day when they are addicted to something. And whether it's the behavior or the drug or anything else in between. And so that's how we teach it in peer support, in my classes at least, because I find it very important that the tools that peers use, no matter which avenue they work in, are exactly the same. They're simply used different.
That's good. It's really good. And it's important because everybody's experiences are different, and keeping that in mind, I think leveraging our personal experience in the way that you mentioned is really important. One of the things that I will drop in the chat here is a document I received from a friend of mine, a colleague of mine, and it's just a survey on stigma that came out today. And I was really shocked because the research that we've done is usually used a pretty small sample, and it's been over-representative of white and highly educated, which I think some of, if with clinical training, right, you get a certain amount of training around things like stigma and cultural competency. But this is a sample from general population, and it shows quite a bit of how much stigma still exists. I mean, across the board, it's the majority of people with negative attitudes towards anybody who has a substance use issue. So it seems like one of these things that at times can feel immovable. At other times, it's really hard to educate the entire society at one time. So it's something that we just have to generally chip away with. So in light of the previous questions, one of you, how about Brooke, help explain what systems of power and gatekeeping things like barriers and obstacles that exist between a person in need of medication and their ability to receive and maintain access to it, just at a regular level. Like if I needed medication, what would I be facing?
Mm-hmm. Yeah, there's so many. So I'll give the concise version and what's sort of the top barriers, right? And so I think, what I've seen a lot of it is as a top barrier is kind of this like turning the medication into like this carrot, right? That people can get if they do A, B, C, D in the way that they're told they need to do it. And I think, that's super problematic, right? I mean, we know these medications cut the risk of overdose death in half. And so just like the idea of housing first, we know that if people have homes, like then they could possibly work on making other positive changes that they want to make in their life. But it's kind of hard to get to IOP when you don't have an alarm clock in your tent on the sidewalk, right? Like, so the idea of like meeting basic needs first and then, the ability to work on things later. When we make the threshold so high for folks to engage in services and receive medication, and also have practices that abruptly will cut somebody off if they fail to be, I hate using the word, so I put in quotations, compliant, right? Then I think what we're doing is actually promoting death rather than preventing harm. And so really having low threshold access is really important. And the barriers, often are there's some regulatory ones that we're seeing progress with when it comes like things like mobile methadone, for instance, right? Like I imagine that person's not going to have to be at the van. I hope most systems won't require that person is at the van at the crack of dawn and that they have to find a job that they can get to later, right? And that person is not going to be required to attend individual and group counseling sessions at that van if they say this isn't really helpful for me. In fact, it makes me want to use more because for whatever reasons. Like I hope that there will be lower threshold. So it's really getting access to the medication first and not like dangling in front of people as like this reward that they have to sort of bark to our orders and do what we want them to do in order to get. That's probably like if we could remove that barrier in itself and made access to MAT as readily available as Advil is if I have a headache, and then we would see overdose deaths, really just drop dramatically.
Yeah, it's important. I've interviewed research subjects that drive sometimes 2 hours one way to get their daily medication and still have, and these are middle-aged mothers, right, with children and like all of the stuff that goes along with that, and still having to drive, 2 towns over just to get medication. It seems like if society's trying to incentivize people towards wellness, then making things easier rather than harder would be the way to go. Christina, do you have any thoughts?
Yeah, absolutely. And more on, the atmosphere of these services, right? So, oftentimes a lot of these services, there's the unintended consequences of the policies and practices that are created by people that aren't directly impacted. So that, we see a lot of what sometimes referred to as a negative loop instead of a positive loop where they're plugging into their community to ask them what is your experience of these services and how could we make them more accessible? So really, what we're talking about is an inability to access entry-level services. And we have tons of data that shows us that it is not a funding problem. If we had all the funding in the world, that people still could not access these services. And that these services, not only are they not accessible, but they're not sustainable. They're more likely, and there's a number of different reasons depending on, again, the identity. So in case anybody is on, what do we have here? 201 people, each one of us. It's not a matter whether or not we are racist or homophobic. It's about how much tendencies we have. So me, myself, myself, I am an Alaska Native person. Sometimes this is what's considered, white passing, but to not like central it in white. I'm not as dark as my mother, who's full Alaska Native. This means that I myself was born with narratives, of to be racist against Alaska Native people, that I believed, and that became internalized, that there were parts of myself that I didn't like because of what people said, and how that translates to substance use. I hate it. In one of the pathways of recovery, they call it incomprehensible demoralization. And what that means is, how many cups of sugar does it take to get to the moon? It is incomprehensible the way that you feel about yourself. And a big part of that is how people treat you. So whether or not, and when we think about biases and stigma, there are these overtly things, but essentially it is this deeply othering. When you are in the presence of somebody else, you feel that you're being judged, that you're not enough. And sometimes, it could be the question. Maybe the question was totally right, but it is the body language, it's the tone, it's sometimes we call this work the work of the unseen. And that is all present in the room when we're asking these questions. And, these, our healthcare plans are only as good as they are honest. So really talking about how to have these relationships, that means that people have to do that internal work to find out. The recovery pathways, it's all about that inventory to find out, where you begin and end. And even now, as I'm saying these things, if there's something that's coming up for you, that is your work. But to look how that, translates in programs, we know that people who, don't have identification, who have been incarcerated, there's so many different ways that have children who, don't have access to transportation. And then we also know that for people who, it is a hard thing for people to believe that there are people out there who used to binge drink and now only drink on weekends, who were considered to have that there are stages and cycles of addiction, who are considered to have a progressed, fatal stage of addiction, who continue to drink but no longer have that chaotic relationship with alcohol, or who used to inject methamphetamine and heroin, who now only drink alcohol, or who use prescription medication. That people like that do exist, but it's not something that we talk about. And how that translates into policy is that, let's say that you took 6 months to get into MAT, and you're there, but then your UA shows something else, then people are immediately exited from the program. And we know that has incredibly harmful consequences. I mean, there's a lot more I could say about it, but I'll give space for somebody else.
Yeah, I think that's really important. The uptake of this, the kind of juridical mindset that people face walking into the system, they are already challenged at face value to enter into a system that already seems suspicious of them and their motives. And it begs the question, what is this system for if that is the initial confrontation that someone has with it? And it's not just, we have a sort of an ideal type of person who may enter into the system, but it's not just somebody who is struggling with opioids, right? Rarely are you going to have somebody who has just an opioid issue and everything else is okay, and they just need to get on some medication. And even if that were the case, it wouldn't be any easier for them. And I think that that's a real challenge. So in light of the stigma-related barriers, such as the example that I come up with is recovery housing that doesn't allow people on medication to live there. But what do each of the panel members feel is the most important step once someone is plugged into medical stabilization, and then kind of the next step after that, and what challenge they may face that's related to stigma? So why don't we start with, let's start with Rachel, and we'll just kind of go around.
Sure. I guess it's hard to answer what's the most important thing. That's going to kind of relate to them and what's their most important thing. I think it's interesting that, like I mentioned, standardized tools and assessments before, and it is hard to hold that. We're using standardized tools to provide a person-centered service. And sometimes those don't connect, and we really try and provide person-centered services. And that is, that it's challenging, and there's a lot of, it's a big onion. So once you find another thing, you're going to find another thing. Answering one question or finding one solution is not going to fix them all. You're going to uncover more things. And connecting to resources it sounds really cliche and easy. It's not that easy, but I guess that would be my initial response. But as a provider, also to recognize that once we've started that medical stabilization, the barriers are not over. Like telebehavioral health is huge, really helpful, and it's not a barrier-free model. Not like Brooke mentioned, the person on the tent who doesn't have an alarm clock probably can't be Zooming. And so continuing to look at it from a how can we reduce barriers rather than, well, we've gotten them this far, the barriers are over. It's not going to be over.
Yeah, and that brings to mind something I remember from social work training, which was, dental care and a haircut are like required to get a job. And that's something that there's no listing of this in the manual, right? It's just not something that would come up. And yet it's easy and accessible. And it's, it's one of those things that we would overlook if we were taking the measure of it, right? Jen, what are your thoughts?
When I'm thinking about barriers, I think about any label specific to the diagnosis, specific to their gender or identifiers. I think about anything that singles them out as the way to work. You want them to be as authentic as they can in front of you. So labeling them doesn't do anything. So when I think about bringing someone into services and getting rid of those barriers, I think about meeting them where they're at. I use the 4 E's. I engage them anywhere. I don't care. I educate them of all the options that we have in front of them, but empower them to make the choice themselves and then evolve into their most authentic self. That is my tool that I teach in everything I do. With every client I work with, I will always model the 4 E's because that's how they get in charge of their journey.
Brooke?
I concur with the previous panelists. I agree with what was said. And yeah, I was thinking of something I heard often for people who find that 12-step sort of mutual aid fellowship involvement is the pathway that they feel like is what will work for them, right? Like even with the use of MAT. And I've heard the guidance given far too often of just don't tell anybody. And it comes, I think that the attention's great, right? It's this is your body. Do you go in a meeting and tell people what medications you took today, if it was any other medication? And I get that, right? It's a very logical argument. But because of the stigma and discrimination that can exist among some people in those, any setting, honestly, if you get a bunch of people who've been indoctrinated into what I was indoctrinated into and had to unlearn, you'll see that pop up. And so this idea of just don't tell anybody, don't just keep it to yourself and don't share about it, don't let anyone know, and you'll be okay. So does that provide safety, right? Absolutely. And that's first. So I think that conversation is important. If these are some of the risks of self-disclosing in spaces, whether it's recovery spaces, employment, housing, education, family, whatever, right? I've had family members who say they can't live here until they're off of that money, off those drugs that they're using instead of, whatever they were using before. And so I think yes, that's great for safety, but the benefits of any kind of group participation, right? So this is the social work hat. Why do people participate in groups? Why do we run groups, right? Because there's benefits of group participation, and you lose most of those benefits when you can't bring in, I heard your authentic self. So what we're saying is for you to be safe, and it's not just limited to 12-step meetings, and meetings are affirming and embracing. So I'm not generalizing it. It could be wherever. But to tell someone you have to be inauthentic in order to have safety, and in order for this to work for you, it flies in the face of everything we know about sort of, the recovery journey. And I know recovery means different things to different people, but if it's all about sort of, for many people, unearthing like their true self, like who they really are, like think like Dr. Gabor Mate's model, right? Like just that, like, it's kind of like just getting down in there and being their authentic self. I mean, there's some theories that what drives a substance use disorder is the inability to be our authentic selves in the world. And that's why we see increased risks of substance use disorders among marginalized communities like the LGBTQ plus community I'm a member of, for instance. So I think I just really struggle with like, and I don't even think this was the question and I apologize, but I just think that like, we have a huge problem on our hands if we're saying that like you have to basically do the very thing that may have drove your substance use, which is not be your authentic self, in order for you to be safe and okay in this world. And I don't know the answer. I guess I'm a panelist posing a question to all of you that are 4 hours behind. Like, how do we grapple with that? How do we make sure that people are safe, right, in whatever space they feel is best for them or they need to be in? But also like create safety to be their authentic self, because I don't know that we'll get anywhere if we're telling people to hide a part of them, and definitely in a group setting. If I had to hide that I was gay, which would be hard, obviously you can see my head, like I can't even imagine that's a part of my humanity, right? And how would recovery have looked if I had to? I mean, my recovery has been about laying it all out. Sometimes much to people's dismay, but it's who I am, right? And so I think it's something we have to grapple with.
Christina?
So good, Brooke. You're cracking me up. I think, okay. So, I mean, what are the barriers? So after somebody's plugged into MAT, what are the big barriers? So the first thing I want I don't forget, I want to talk about interfacing with systems. And then the big thing I'm really, really super passionate, I want to talk about is language. And so so after they're plugged into a system, right? So then it's interfacing with any of those systems. So Department of Corrections, you go to jail, you come back out of jail, you're on probation, you're probation officer. That means that what education do they have? Let's say that you're pregnant, you have a baby. A lot of policies for medical providers is that they report immediately to child welfare. And so regardless of, people are saying, but I'm in recovery and they're trying to take my child away. And so that's something that we've been working to make a lot of progress on, but it's understanding that each of those different systems have a totally different idea of what recovery is. And that is driven by the language that we use. The language that we use has to be inclusive of the multiple pathways. So I encourage you, all of you, to really think about what language you use and where that came from and how that supports a specific pathway that isn't inclusive of all of the pathways, or to harm reduction, which is really the model that we all need to take. That all of our positions should be that we will save, that we will not save, that's the savior model, that we will work with people to be around for as long as possible so that they can get the help that they need, and to choose what pathway works best for them, because that is evidence-based. And that is also, to bring the two together, how can we have evidence-based and that also be client-centered? That's what it is that people know what's best for themselves. So language, we use clean, dirty, those are based on morality. We've moved from substance abuse to misuse, and this is really confusing. We're talking about how trauma intersects with violence. And so we're like, abusing who, right? So she was abused. You can't abuse an inanimate object. And so even if you've moved away from saying abuse, there's still morality attached to it by saying misuse. So did I misuse the prescriptions? According to who? Because they kept me from taking my own life. They kept me from working through my trauma. So then just avoid the question at all. Avoid any of that. We don't even have to have those conversations. It's just substance use or chemical use, or it doesn't have to be any of those. And it doesn't even have to be a disorder. It just is. So when we're talking about sobriety is, if you say like sober curious, that is a specific pathway that is abstinence-based. And so I was just in court yesterday. The judge could not fathom when she was saying, I'm in recovery from heroin and methamphetamine. He goes, but you said that you had a drink on New Year's. He goes, then you're not in recovery. But because he's referring to sobriety, and she herself had said sobriety in conjunction to recovery. But it's understanding the language that is associated with all of these different pathways. So probation officers would understand better, MAT is a type of recovery. Does it, and how that comes up against Alcoholics Anonymous, Narcotics Anonymous, and the way that, some of these different pathways have really, had an influence, like our Alcoholics and our AA and NA, how that's played a major part in our treatment providers, as well as like the pathology and the ideology. And I think that there's a lot of science that behind the language that we use and where we place people in our brain. And when we other people, we actually lose the ability to feel for them. So we don't feel empathetic. So if we know that ending shame and stigma, a big part of that is having that empathy, using the language that's connecting. So really humanizing people through the language that we use, and telling the whole story, telling the whole story about what use look like, also about what recovery look like. There are some people who are in recovery who are not CEOs. They're just getting by. They're just fine. And that they're making it day by day. They're just doing okay. And that's a story that needs to be celebrated. Me as a human being, while I was in active use, had just as much worth and value as I do today. So it's looking at all the different ways that sexism, classism, racism, able-bodyism play a part in our interactions with people. I'm trying to think I think those are the big ones. Oh, and then acute care versus long-term care. I think that's the other really big one. We put so much emphasis on getting people, to where they need to be, instead of thinking about this as a lifelong journey. And trauma really being the thing. We forget that. We know that trauma is the underlying cause, but we often forget that. We're like, well, now that you're plugged in, we forget that there is like this bell curve that happens for people, when we look at the way that people really experience trauma, and all of those things usually end up coming up after you get safe. You come out of that freeze zone after you get safe. So if you're working with somebody who all of a sudden is really angry and is like pushing you away and is telling you to F off, even though you've done a ton of really great work, it's to understand the enormous part that trauma plays in people's experience. The other thing is traumatic brain injuries. It's also a really big part of like the people that we serve, and the intersection between trauma, domestic violence, sexual assault, and substance use.
Excellent. Yeah, those were all really critical points, and it ties into some of these some of these other questions. One of the things we talked about intersectionality, and one of the things that I think is really important is to understand how professionals, judges, the public are sometimes they elicit certain emotionally charged reactions to particular identities, and at the intersection of substance use disorders. Pregnancy and opioids, for example, being a major one. What types of implicit assumptions about these identities do we really need to push back on as professionals? So for example, you were talking about in the courtroom setting, and what the judge had said. And my experience has always been that the judges are genuinely want to help, but they are governed by precedents rather than science. And so they go by what the law says and what history of that law says and what the kind of common conceptions are. So when it comes to these other types of identities, like people with opioid issue and who might be pregnant, or any other type of intersecting identity, how do we push back against the types of emotional experiences that someone like a judge may have, and do it in real time, because that's the difficult part. And why don't we start with let's start with Brooke.
Sorry, Austin, I was having like a technological challenge there. Can you please repeat the question?
Yeah, so I was talking about how some identities at the intersection of substance use disorders elicit an emotionally charged response, particularly by people like judges or other professionals, or housing officials or whatever. And the example I used was someone who's pregnant and has an opioid issue, for example, in a courtroom? And how do we push back against these kind of compounding forms of stigma? And how do we do it in real time, which I think is the most important part? How do we correct that stuff as we move along, as we walk clients through that kind of stuff?
Yeah, so, it's hard because I think we have to start from one is racism, right? And we could have a whole nother conference. I would love to actually come to Alaska. I've never been and want to come. So have me. I would love to come. But yeah, it's definitely racism, right? At least the United States has driven drug policy. It's baked into the whole thing. So racism. That's a very short answer. And I think that we have to name it, right? Like what it is. And so, for instance, I talk a lot about to again, most people's dismay about this narrative surrounding the opioid epidemic, right? And at least I'm in an urban area in Philadelphia, Pennsylvania, so I don't think it's universal. If I, say for in rural areas, maybe it's a different thing, but the narrative of little Johnny from the suburbs who was a great kid, never, he wasn't the kind of kid who would use drugs, A student, star of the soccer team, walks the neighbor's dog and mows their lawn type guy. That Johnny has his wisdom teeth pulled out or he gets a soccer injury or whatever. And Johnny ends up addicted to opioids. And then Johnny winds up transitioning to using heroin, or in my community, it's all fentanyl. We can't find any heroin. And, and that's why Johnny's where he is. And Johnny's painted as this innocent victim who's not like those other people, not let's be honest, black people, black and brown people who chose to use drugs and chose to be these immoral, undesirable people doing bad things for which we should punish them and protect everyone else from, right? That's the messaging in the war on drugs was essentially, it's been a very long month, so I'm just being, a little bit extra candid than usual. But I mean, the honest reality is it's always been how do we protect white women from these black and brown drug users? And how do we protect the desirables from the undesirables? How do you see it with same-sex marriage, right? How do we, that's a theme that goes in so many different issues. But with this narrative, right, it's kind of saying little Johnny, people with the opioid use disorder. And when I say people, I mean white people. That they're different. They're not like those other drug users. And in turn, there's now a more deserving class of drug users because they didn't choose to use drugs. They were tricked. They were duped. It was all the doctors and Purdue's fault. Where no one's saying no, little Johnny was with his boys on a Friday night and they were hey, I got these out of my mom's pocketbook. Do you want some? And if little Johnny was like me, it was yeah, I'll take 6. And there's a very different entry into, and one that's more aligned with everything we know about the development of substance use disorders. Sometimes I'm how did we all get so blindsided? What happened to the field? Because we know that, that we're talking about biopsychosocial, sort of, spiritual. I mean, we've evolved those things, sorry. But it's a complex, very nuanced thing of why the minority people who use drugs, extreme minority, I was in it, right? But the minority people go on to develop a substance use disorder while the majority don't. And so the majority of little Johnnies didn't go on to develop an opioid use disorder. They, took their Percocets or Oxycontin and then had a great time. Maybe things didn't go so well and they're I never should do that again. Maybe they had another negative experience, or maybe they just moved on and developed, right? And didn't want to do it anymore. And they didn't have a substance use disorder, so they could be no thanks, no oxys tonight. I have a game tomorrow. So I think it's just we have to tell the truth and we have to name things what they are. And honestly, in my perspective, the whole narrative surrounding the white narrative, right? The whiteness of the narrative, the opioid overdose death crisis is steeped in racism and it's steeped in sidestepping the very stigma that we were talking about that surrounds MAT. Because that same stigma really applies to anybody who is doing anything that is seen as impure, immoral, or undesirable. And we need to get away from that. So I don't even think I answered the question again, Austin. You all might not have me back. Don't get me for a panel. You gotta give me an hour to talk because I clearly don't follow the rules. But hopefully I covered something.
That was really good. And the quote unquote good kids with bright futures. right? And the tragedy of good kids with bright futures being exclusively suburban, exclusively white, and that being used as a political tool to try to soften criminal justice response for that particular. So if you're a lawyer, you want to make your client into a good kid with a bright future, right? And you want to get them as far away from those quote unquote others so that the judge will be nice to them. Christina, you want to chime in here?
Yes, absolutely. No, Brooke, you are spot on. And the question is, what are the disparities that, people really have? And you nailed it. What we're talking about is the intersection of marginalization, right? Depending on people's identity and the part that plays. So, I mean, if we're, and it's pitting, right? So for our clients, that is, the people that is the good clients and difficult clients based off of, even what type of use that we know that there's a lot of stigma about stimulants, right? There's a lot of stigma about methamphetamine. There's a lot of stigma about what type of, even people who are inclusive of mental health, there's a lot of stigma about what type of mental health, right? So I can have anxiety and depression, but if I tell anybody that I have borderline or that schizophrenia, then those are ones that people are afraid of and won't work with, rather than, really looking at the underlying cause. And really what it is, it is compounded, complex, multiple layers of trauma and imbalances of power, based off of these narratives that we have. So, and really, really understanding, the difference between the two. There's a reason why this person over here, for instance, Johnny, has the ability to recover those natural supports and will probably, could write you a thank you card, could go on and get a job, could be a success story on here versus, the person who is least likely to do that. And that is because of all of the other issues. So at the end of the day, then they're also dealing with sexism. They're also dealing with racism. They're also dealing with classism. And we know, for the DSM-5 has said that racism leads to PTSD. And that is one of the reasons that, causes people to use in the first place. And I think it was Rose that said, well, who creates those laws in the first place, right? That is, so even when that isn't present, that it is backed up by the state, it's sanctioned, and when we look at how that translates over to the types of harm, like we have the narrative for understanding, the connection between the types of violence that people are experiencing and how that translates to substance use. So here in the state of Alaska, Patrick Sidmore's recreation of the ACEs studies shows that 70%, right? So here in the state of Alaska, women have a 50% chance of being physically abused, sexually abused, or both. Unless you're an Alaska Native person, then it's 85%. In some villages, that's 100%. And of those people who experience violence, 70% of them turn to substances. Now, if you read the newspaper, the majority of them get blamed for their own sexual assault, depending on what was happening. That's what people told me, had I not dressed that way, had I not been there, had I not been on drugs. We also know that from those reports that some of them get blamed for their own death. We're blaming people for their own death, but that's completely based off of, their race, their identity, the socioeconomic status, and how and that ends up being confirmation bias. So if you don't know the whole story about, the presentation that we listened to yesterday about the history of Alaska, right? That violence is not a part of Indigenous culture, that violence is a learned behavior that has carried over into our culture. And actually, if we look at those statistics, the majority of violence that's happening to Alaska Native people isn't by our own culture. It's by people outside of our culture, which is really, really important to understand. But if you don't understand how trauma connects to disparity, we know that from ACEs. It would be great if we had a bigger picture of adverse community experiences or adverse collective experiences to tell that full story. But if you just see a lot of Native people who are struggling, a lot of them who are incarcerated, a lot of them who are not able to access those resources because of racism, because of discrimination. And HUD just released their reports for Alaska that showed the majority of Alaska Native people are not able to access housing. They're not referred to housing. Housing and Homelessness Coalition just recently released those reports. So we have what has been personal experience is backed by the data. So if you don't know the whole story, then you just think, oh, that's because of them. And that's what confirmation bias is. So it ends up being this really ugly, negative, cyclical circle of violence that is individual, that is community, that is complex, that is collective, and that is institutional.
Hey, anyone else want to weigh in there?
Yeah, I'll weigh in a little bit. I understand that sometimes it's the using the privilege of the credential of the I'm the support person to in the moment have to say something like, you realize we can hold two truths at once. But I think there's a lot of feeling that there's one truth, just like there's one path to recovery. There's one way, there's one truth. This is fake news if this is not. And that's not true. There are many truths that we can hold all at the same time. And I think that's true of ways to recovery. That's true of ways we can help our people that we're working with get to a path and try and identify some of these intersecting identities and statuses, is to say that can be true and this can be true, but they still need this help. Like Christine said, even when she was in her youth, she was still worthy and worthy and valuable. Absolutely. That does not diminish the need for services, the need for what she needs for her life in her circumstances, which are going to be different from someone else who might look like her, have the same job as her, make the same amount as her, have the same number of kids as her. It's still going to be different. And I think it is our privilege and our duty to try and do that interruption to say, there's more than one truth here, and we have to try and hold it at the same time.
I want to attach to that, Rachel. You're so right when it comes to multiple truths, when we're talking about multiple entities for each person that walks in front of us. You know, the joke that was made to me and my sister when we walked into therapy together, almost 20 years ago, was there's no way the same thing happened to both of you. And I was like, excuse me? Who are you to know that? What, because we're white? Because we have a 2-parent home? That's not how this works. You know, the way I teach this in my classes now, my seizures, cancer, my skin color, my gender, none of this is a freaking drive-through order. We don't just get to go put ourselves together however we want. So we need to value all these differences when they show up in front of us. We need to value their ageism, their genderism, their identity as a whole, to help build them into their most authentic selves, because that's who deserves this life, is their whole self. So I want to agree with all three of you. That was just a very powerful conversation.
Yeah, that was really good. And it's this is where we start to edge up on some of the inspirational stuff that can come out of this work. And that's one of the things that's really important for us to keep in mind. I try to think about the fact that the systems that people participate in, the issues that they may have, and the identities that they may carry are really just a starting point. And that is where we begin to understand somebody as a whole person, and where we begin to inquire as to what we can do to be of service to them and to help them. On that note, what values should those of us who work in this field seek to promote in order to help reduce stigma, and particularly the effects of stigma, and to challenge the barriers that we've discussed? So an example would be, one of the things that gets thrown around a lot, since I do research, is science and evidence-based, which in my mind is very useful and is theoretically correct, but it's also used by people like policymakers to strip down any sort of service down to its barest components that they're willing to pay for. And so it reduces the robustness of any service in the name of quote unquote evidence. And so one of the things that I've always tried to add to the discussion of science is the idea of community and solidarity as two of the values that have to go along with science particularly when it comes to marginalized populations and the systems that that they may come across. So why don't we just go in reverse order, and we'll start with Jen, and you can tell us a little bit about the values that people that should have, and the values that you in particularly have and hold dear.
You know, when it comes to values, I think for me, it's really about focusing on instilling hope. I don't care where you come from, what your gender or your race is. I care about you showing up today and being present in your own recovery. Because that is the hardest thing to do, is take that step every time they make those appointments. My primary population throughout my career has been our more vulnerable ones, the schizophrenia diagnosis, the dual diagnosis, because they're self-medicating those voices and really trying to be a normal person. And my favorite thing to say to those guys when they showed up at my office or met me at a coffee shop in town was, thanks for trusting me today. Because it's not about me. It's about how I have at least helped them feel like a whole person today. It's about them feeling okay being broken today. That whole mentality of it's okay to not be okay. So the value that I hold dearest is hope, and the ability to instill it, to ripple effect with it, and really build that dynamic of compassion and empathy and support across the board. But it all starts with just instilling that hope and acceptance.
Rachel?
Yeah, I think being aware and cognizant of our language. When Brooke was talking about, our little Johnny, I thought our language, and we've said this, and it continues to be true, is that our language is so important, and we need to invite people to correct us and offer suggestions and change. Just when she was talking about that, I thought, there's a real difference in how we talk about whether someone takes medications or these are the drugs I'm going to prescribe for you. And it often has to do with what we perceive their background to be, whether you call it a medication or you call it a drug. And that can be really stigmatizing and, reinforcing things we don't want to reinforce. I guess the final value I would really say is it's sometimes be a subversive disruptor, I guess. I was one of the first people at my agency to start putting my pronouns on my Zoom. That wasn't an agency policy. It wasn't an agency policy not to do that. And once somebody does it, everyone starts doing it. And it's because I started doing it because I started seeing other people do it. And I thought, gosh, that's a really good idea. I need to be more open and clear about that. That's how we learn. We learn from other people. We learn the language we use from other people who we respect and value. And then we can kind of be a little subversive disruptor in our own worlds, which is going to have that ripple effect to other arenas and other people who respect us and value our opinion. And everybody in here has such a unique, I certainly don't know everybody in here, but the people who come to this conference, the ripple effect we have in just this state alone is huge.
Yeah, and I don't remember who's next, but
mine was quick, Austin. Just love, and I feel like I'm a social worker. I get it. In social work, I think it's one of the disciplines that is at least a little more open to using the L word, right? Not the show, but the word. I think that's what it comes down to, right? We know that what determines positive outcomes in healthcare more than anything, more than any evidence-based practice or intervention du jour of the decade, is the relationship between the clinician and the person receiving services. I was mad when I found that out because I spent $150,000 of student loan debt for an MSW degree. And I was like, oh, it's a relationship. I knew that. I could have saved myself a lot of money. But I obviously picked up other skills. And so I think, what is relationship to one another? And it all ties together. I mean, relationship one is about authenticity. If it's a deep relationship, a meaningful one, a an intimate one, and one that often promotes like growth. And so like, it really does come down to love. And I think that at some point we have to stop being afraid to say that in clinical settings, right? And be able to just be real. Like I know in my work, when I managed, 2 office-based opioid treatment programs, OBOS, right? That most days it was as low threshold as it gets. So often we saw somebody once because it was like, yo, I'm going to Clean Slate. You want to come with me and get a script and then we can sell? Yeah, I mean, like I would have done it, so I don't judge it. And then, we had one chance to engage that person though. So if you were coming just to get some Suboxone to go sell, to use the money for whatever your goal was, then okay. I mean, I obviously don't condone that happening on a continued basis, right? Unless you want the DEA, knocking on your door. So obviously that you can't continue to allow that to happen just because of the regulations we have. But I get that, right? And so like just being non-judgmental, like if the person if you're able to engage somebody in a way where they don't feel judged or stigmatized or shamed or like they're going to be punished for being honest and like doing what's a very resourceful thing to do, honestly, right? For many people, then that really promotes healing. And at the end of the day, often the thing that I did most, the thing that felt most effective, especially when COVID hit, because I was still there when COVID hit, right in that setting, was just offering a hug. Like honestly, just offering a hug, or just offering some kind of human contact, offering a cup of coffee, or whatever it might be. Going one extra step is what I used to tell my staff. So whatever it might be, right? Like if someone has paperwork to fill out, like kind of checking in and saying, "Hey, how are you making out with that? Is there anything I can help you with?" Versus like, "Here, can you fill this out?" And then, I mean, I've had that happen, right? And I'm like, "What is this? Why is there 600 pages of the same thing being asked of me?" Or stuff that I don't know, like how much money did I spend in the past 30 days on using? How much money did I have? Like, let's say it's going to take a while to figure that out. So I think just love and like normalizing that. At the end of the day, this is just Brooke Feldman's personal, like latest philosophy that I'll probably change. And you can follow me on Twitter to see what it is next year. I think that if you think about our evolution, right? We have these structures that did not exist for a very long time. Our healthcare structure, our healthcare system, the behavioral health system, like the different disciplines that we spend $150,000 to get 3 letters or 2, which is even more expensive. I feel like if you have 2 letters, it should cost less than 3. But Austin's working on a very much more expensive 2 letters that I don't know if I want to do ever. And so I think like, for a very long time, we didn't have all this. You had community and you had like sort of the community sage or elder or just the wise person, the shaman, whatever. It depends on the community, right? And you had like the person who was like the healer, like whatever it was they were called. And people just took care of their own, and maybe not always the best, most efficient or effective or, way, but like we went from that to these structures that we know are carceral, that we know are racist, that we know fail people overwhelmingly. Not that they never work, but we know that in general, they are more likely to fail than to work, right? Even in the physical healthcare system, we have the most expensive and least effective healthcare structure of developed countries in the world, right? So these structures we've erected, they weren't here when we got here. We built it. They are not working. They're not helpful. They're making somebody rich. I know it ain't any of us on this call or this Zoom. It's definitely not me. I drive a Kia Sportage. And so I think like maybe at the end of the day, that what also got lost as we built all this structure is the key ingredient. And I think about this a lot with peer support services. Again, a whole nother conference. Holler at me if you're having a peer support conference. But like when we sort of introduced that magic ingredient that people with lived experience have, which is honestly at the end of the day is love and compassion for somebody because they've been there. Because as human beings, it's really hard for us to have love and compassion for somebody unless it affected us the same way. Like if we're honest, same here, right? I like the whales, like I care about whales, but like I'm not out there fighting for them because it doesn't impact me, right? So like I think that what we lose as we erect these structures that are super harmful, don't work, cost a lot of money, is we lose that love. Like we lose that love ingredient. And then it's not okay. Like the higher up you go, it's not okay. And the one thing that would heal folks, like honestly, like the one thing that we know works is like, that's taboo. Like, no, you can't care. You have to have boundaries. Like don't treat them like an equal human being. That's a client we're talking about. How dare you show love? Like, and we all know I'm not talking about like sexual or romantic love. I'm talking about just like, positive regard love. So I'm sorry, you can't, I'm not gonna be allowed back, but it was a long answer again. But the short word is love.
I love your lack of filter. I'm just going to tell you that.
Thank you. It's late. It's 7:14 p.m. here, and I taught a class before this, and I had a full work day, which was very stressful because Philadelphia's a mess right now. So you do get the unfiltered, slightly all over the place version of Brooke tonight.
But that's part of the healing, right? So we got the authentic Brooke. That's what we're talking about. I think, to really like sum it up, and we love checklists and compartmentalization. That's part of the culture, and that's also another thing. That's also a totally other thing. But we're talking about the oppression of professionalism that allows people to really, really show up. And greater than what values we want in place is how do we put those into action, right? You cannot give something that you do not have. So we have, and that is the workplace environment that people are. So whether we're talking about any of the different modalities of care, everything that people need out there, we need here. Sometimes it's referred to as the curve method, but I call it fluidity. Everything that we know that our clients need, the people that are providing those services need. So a big part of my job is working with your employees. Your employees, we have a ton of statistics that say that a majority of them will not come to you for help, and a majority of them will not receive help from you because you have not built that relationship with your employees. They are not in an environment where they are supported. They're not in an environment where they feel accepted. When we talk about racism in the employment, when we talk about sexism in the employment area, when we talk about classism, right, we're talking about the hierarchy, even education. That is a really, really classist, elitist thing, right? We've known that from peer support, trying to get peer support, workforce development to say, you guys have totally different degrees, but you're equal is a really, really hard thing for people to accept. Educating the medical community from people who have lived experience. They're like, no, we don't have the same degree. I paid a lot of money for this. I think I know what I'm talking about. Is a really acknowledging that, again, if you want people to have values and the principles that we know that people need, then you have to give them the experience of it. And that's all, that's part of organizational transformation and healing. So really having something in place for you to listen to what, maybe your only Black staff person, your only person of color talking about their experience of marginalization within your organization, and how that the staff that you have is not reflective of the community that you're serving, right? We're talking about cultural responsiveness. We're talking about inclusion. We're talking about equity. We're talking about accessibility, and not just do you have a ramp, language access. We're talking about, and not just for the big things. It's those one-on-one, those intimate relationships, and it is all about relationships. 100%. But a lot of your staff are struggling with mental health themselves. And if they go get help, they could be fired. A lot of your staff are struggling with substance use because they call me and we have those conversations and we write those letters together and we look at what state and federal laws will protect them. And they're afraid. It's a small community that they can't talk about that. They're struggling with domestic violence. They're struggling with sexual assault. They're struggling. How many of your staff are suicidal? These are the calls that we get. And this is the oppression of professionalization. And these are the people who are supposed to be providing those services that are full of all those things. So if I have never had the experience of being fully accepted, and that's the only reason why I have that. The only reason when I'm sitting with another human being, I use the pronouns that they use because somebody has told me that they light up, that they feel the best version of themselves. Somebody taught me how to do that. And it's an understanding that we are human. Like humanizing this experience to the fullest, being able to make mistakes. Ending perfectionism, like normalizing what it means to be human being, that I am going to stumble, that I'm going to fall, that I'm going to say the wrong thing often, right? And celebrating that, and those are not something to avoid, that, that there is really the embracing of that. I see a lot of Brene Brown quotes that are coming through here, but it's true. There is strength in the vulnerability. Being able to have those real, authentic conversations with the people that we're working with, to figure out, again, I think that there's a lot of parallels between individuals and the bigger. Small is all, right? And that is that there is never anything wrong with anybody. There's only something missing. But if you do not believe that for yourself, if you do not believe that you have the ability to overcome whatever's in front of you, then you won't be able to give that for someone else. If you don't have absolute acceptance of where you begin and end, what your deficits are, where your strengths are, you're not going to be able to give that to somebody else. So it starts with your organization and then moving out.
I want to touch on that for a second because that's actually something we worked really hard with at AKBH. This started with an email to leadership and moved into the very strong teams we have now. And my team members know they can call me, they can knock on my door, that I am not going to judge them. I'm not taking a note for their HR documents. This is all about the fluency of doing this job well. And that the leadership here wants to hear everyone's story. They know everyone, just like I do, knows everyone has some dose of recovery stories in their past, whether it's someone close to them, themselves, or, a family member. We all have that connection. It's how we've used it in our story to get us where we are. And so there's a very fluent dialogue from the bottom of the totem pole all the way up in our hierarchy of agency leadership, wanting to hear these stories, wanting to share them and empower the teams. And I can't agree enough that if you don't have that, you lose team members. You lose their ability to do this job and be present because they're so lost in themselves trying to stay whole. So yes, please touch on that with your teams.
So, wow, first, what a wonderful, amazing conversation. We have a few minutes left, and there's a question that maybe the panel might like to address, although I just a second lost the chat. Okay, let me try and get it back. Well, let's see. Now I lost the question.
Cheryl, while you're looking, I did see a question come up a couple times. How do we be research-centered and also client-centered? And I don't know if that's maybe the question you're looking for, but I saw that come up a couple times. And we didn't directly address it then, but I hope that maybe it would be helpful to just kind of connect some dots now that I guess for me, it's having a really big toolbox that using all the research that we know, we've touched, everyone here has kind of touched on the research tells us, we know the research, we have this, we have that, and using all that to still provide a client-centered approach because the research tells us that all our clients are completely different. That's unofficial. I don't know if I can't cite that.
I think that, so I want to say a couple of things about research. And I hope that people have a couple of questions. I mean, I want you to have this lens of equity when you're looking at research. And that is, historically, it has been predominantly white male men who have dominated the research. And a lot of that research is, there isn't funding for spontaneous recovery because you can't profit off of it. But so it's looking at who has done the research, who benefits from the research, and most importantly, who's harmed by the research. One of the things that we can do, all of us, and that is to ask the people that you're providing services to. They know best. One of my favorite quotes that I share often is those closest to the problem are closest to the solution, but furthest from resources and power. And that, and that works. And that's by Glenn Martin, to give him all the credit. And that is, that it's that person-centered approach, but we can also take that as a community-centered approach, collective approach, right? That communities know what's best. Communities know what's best. And it's also an indigenous practice of sovereignty, that people know what's best for themselves. And that's, part of being client-centered is learning how to deeply listen without responding, listen without trying to fix, without any saviorism, just listening.
Yeah.
And I think you all just really answered the question, which was what resources are available to challenge oppressive policies in the medical system that impact our clients. I don't know if anybody wants to add to that, but
I can add a little bit to that. I think one of the things that's really important is that we understand the systems themselves, we understand the histories, and we understand the power that's involved. And namely, there's no way to get around economics. There's no way to get around issues of race. And I mean, it's really important to begin to understand these systems that just because it comes from the medical system doesn't mean that it's completely free of all of these issues. And so spending time understanding power, as a hardcore scholar, obviously understanding, Marx, Foucault, the indigenous and transnational feminist literature. I mean, this stuff is really important. Critical feminism. I mean, this is how we come to understand systems of power. And so when it comes to things like the medical profession, learning the basic resources of just understanding scholarship involved around power and how systems of marginalization occur and how oppression occurs and how it's taken up into systemic ways, in ways that become taken for granted, in ways that we just assume is the way things are, when in fact they're deeply entrenched in historic forms of power and oppression.
The other, I want to say, to bring it more locally, partnering with your local organizations to do cross training. So you are the local experts in your field, and partnering. And this is that systems are siloed, but people are not. So really working to understand the culture. That I'm not going to go to Brooklyn and talk to people about what it's like to be Alaska Native and my understanding of race. Those are totally different. And also stop bringing people from Brooklyn. People, that's the definition of tokenization, like that, looking locally about the culture and the environment that's there to better understand, and you teaching them so that they can screen for substance use disorder, so they can better understand substance use disorder, but learning how to be culturally responsive, equitable, learning from your LGBTQ community about the people that they're serving, as well as doing equity audits. You can do audits for language, you can do audits of policy, and again, there are ways to do audits to listen to the voices of your staff, but do it in a really safe way so that you are not, so there's not a lot of focus and burden, the emotional unpaid burden from the one person of color or the one person who's non-binary, non-gender conforming. It is not their responsibility to teach you where you're missing something.
Are there tools for an audit like that you could share, Christina?
There's lots of different tools out there. So here in Alaska, there's a couple of organizations that have been working together. But as far as like the medical community, another really big one we haven't talked about is lateral violence. I know that there's some nursing tools for lateral violence, and really, for somebody who doesn't know what that means, it just means if we're looking at oppression, pushing down at that type of violence, when you cannot push back up, you end up pushing out. So we end up seeing that, in marginalized communities, a lot of violence within their own communities. I'll do some research and I'll see what comes up specifically. I know that there would be different ones for interest. So depending on, I would say, talk to your community to see where that priority level is. So let's say that you are predominantly serving Alaska Native people, but you don't have Alaska Native staff and you are not culturally responsive. That might be the place to start. But let's say you have had no training on, LGBTQ. Or the role that socioeconomic status plays, or maybe from this training you realize that your staff are not inclusive of clients who are on MAT. That you know what I mean. So it's also looking at the intersection of lethality, like where people are most likely to be harmed.
Okay.
There is some good research on that we use in our training that SAMHSA did between 14 and 19, and there's 60 different documents, depending on the population you're looking at, looks at their barriers, looks at the percentage of the population they make up, why those barriers become a problem in service providing, and lots of great tools on how to better serve and support that population, no matter the race. LGBTQ plus is one that's on there that I reference pretty consistently in the training to help steer our minds to what really is going on in that community and being able to be open to having those dialogues with their clients, and building that space of openness and honesty.
I just want to add one thing real quick because I heard that. Sorry, I know you were like, I'm ready to wrap up.
No,
Sorry.
it's okay. It's fine.
I just want to leave one parting thought. It was great to be with you all tonight. That is sort of a curveball thought to leave you all with. Just as much as everything we talked about tonight when it comes to access to MAT and dismantling and abolishing discrimination that surrounds it, right? There's also the concern because we like to do full on like 2,000 mile an hour pendulum swings, right? Like for some reason. So what has concerned me equally for me personally is the coercion and the mandating that people have to utilize MAT in order to have treatment options. And I see that in the Medicaid, publicly funded system, in very harmful ways, because sometimes someone's like, listen, like I experienced precipitated withdrawal. Maybe you don't say those words. It might be like, that messed me up, and they don't want bupe. They don't want to do the rigmarole of the methadone maintenance treatment. And they don't want the medication, right? We talk about choice and self-determination, autonomy, but then sometimes it gets a little messy and we somehow think it's okay to rob people of choice, self-determination, autonomy. And like, because something's the gold standard, it's like, this is all we will offer you. And if you don't want it, then good luck. And good luck right now means like, hope you don't die until you're willing to do it our way. And so I think we need to be very, very careful that while we're doing the work to dismantle discrimination, increase access, normalize the use of these medications that are miracle drugs, right? Like, it's amazing that we also don't go the other way where we have now eliminated all other options, because people can and do find wellness without the use of MAT also. And so it's not an either or, and we need options for everybody.
I agree. That's a point well taken. I personally have witnessed people being fired from treatment program because they refused the MAT and wanted to, use other tools to support their recovery. So thank
Cheryl,
you.
and I want to say, and I also want people to make informed decisions that detox from MAT, from methadone and Suboxone is a lot worse than heroin, like way, way, way worse than heroin. So detox from heroin usually takes about 7 days, can take months to detox. And it is a lot. And so giving them that information, whether that's the science or just blatantly that it is significantly worse, but that they're going to have help with that, right? So making sure that nobody ever has to, to feel that, because that's another way that, that people can, have the celebration of choice.
Thank you. Thank you to the panel. I'm getting red lights here, so, but thank you very much. This was really amazing. And thank you everyone for joining us today for the 5th annual MAT conference, which is sponsored by the Division of Behavioral Health, NADAC, and thank you to those showing your support for Recovery Day by wearing purple. And we appreciate all of our wonderful speakers and the over 350 attendees who joined us virtually this year. We hope that everyone picked up something valuable, especially valuable for them today. And a few reminders, all presentation resources or materials are available on the MAT Conference website under the Logistics tab. The MAT Conference website will be available throughout the year. Please check out the MAT Conference resource list for contact information of attendees who agreed to share their professional information. For information about CEs, please visit the MAT Conference website for the CE facts. To find a recovery event near you, check out the Recovery Month calendar on the MAT Conference website under the Logistics tab. Thanks again, everyone. We'll see you tomorrow at 8:55 a.m. Have a wonderful and safe evening. Goodbye.